Welcome to American Aftermath. Tonight, we'll trace the entire story of the COVID-19 pandemic in America. At first, it was just a headline from far away. Then, almost overnight, streets went quiet, offices and schools closed, and people were told to stay home. Hospitals filled, families were kept apart, and a new, deadly virus took loved ones long before anyone was ready to say goodbye. All across the country, people watched daily death counts on TV, argued over how dangerous this virus really was, and tried to understand what life would look like now and how long it might stay that way. We'll take our time and keep an easy pace. We'll stay close to the people who lived through it and to the quiet ways this pandemic still shows up in American life today. Before we begin, if you find comfort in calm retellings of the days that broke and reshaped America, you're welcome to subscribe and tell me in the comments where you're listening from and what time it is there. Now, dim the lights, settle back, and let the rest of the day drift while we ease into tonight's story. Now, before we follow the virus into crowded ERs and quiet neighborhoods, we need to step back for a moment. To understand how deeply COVID-19 reshaped American life, we first have to look at what ordinary days felt like in the years when this virus was still unnamed and far from anyone's mind. COVID-19 would arrive in a United States that, in the years just before the pandemic, moved through its days with a different sense of risk and routine. Crowded morning commutes squeezed strangers together on subways and buses, where a cough drew little more than a quick glance. Office workers shared open plans, birthday cakes, and conference rooms without much thought about circulating air. In cities and small towns, people packed into movie theaters, arenas, and churches, linking arms, shaking hands, and passing programs along the rows. Everyday life felt busy, sometimes stressful, yet physically close, and mostly unquestioned for now. COVID-19 would meet a country whose public health memory reached back to earlier scares, yet whose daily habits rarely reflected those lessons. The 1918 flu pandemic lived in faded photographs and family stories, but most people did not picture it when they boarded planes or rode crowded elevators. More recent outbreaks like SARS and H1N1 had worried experts for a time, then faded from the front pages. Many Americans trusted that modern medicine, antibiotics, and vaccines would protect them from the worst possibilities. Serious epidemics belonged, in many minds, to history books or distant places on the evening news. Altogether, across the United States, hospitals and clinics operated at a steady hum that felt demanding but familiar to staff. Nurses rushed between rooms, adjusting medications and answering call lights, while doctors followed packed appointment calendars and late notes on glowing screens. Emergency departments often felt crowded in winter, with patients waiting on chairs in hallways. Yet this was seen as part of the job. Insurance rules, billing codes, and network restrictions shaped where people sought care. For many, routine checkups were delayed or skipped because of cost or time, long before anyone heard the first reports from abroad. For some, in the years before the pandemic, public health agencies watched seasonal flu, foodborne illness, and regional outbreaks with tools that felt technical but routine to most Americans. The Centers for Disease Control and Prevention tracked hospitalization numbers and genetic changes in familiar viruses, updating guidelines while school nurses pinned fresh posters about hand washing. State and local health departments carried out vaccination campaigns, restaurant inspections, and quiet investigations of clusters that rarely made headlines. Many of these offices were small, with limited staff and aging computers. Yet the work moved forward in the background, mostly unseen by the people it protected. Travel tied the United States closely to the rest of the world in the years just before the first news of a new coronavirus. International flights flowed in and out of major hubs every day, full of business travelers, tourists, students, and families visiting relatives. Cruise ships offered floating entertainment with buffets, shows, and crowded pools, where thousands of passengers shared air and surfaces for days at a time. Border crossings saw lines of trucks and commuter cars. Most travelers worried more about weather delays, lost luggage, or security lines than about an invisible virus hitching a ride across oceans. In schools, classrooms filled with desks pushed close together, where students shared crayons, headphones, and whispered jokes across narrow aisles. Teachers moved from room to room for meetings, leaning over shoulders to help with assignments, and thought more about test scores than airborne protection. At sporting events, fans cheered from crowded stands, high-fived strangers, and lined up at concession counters, their voices rising in shared songs. Families gathered for weddings, baby showers, and funerals without counting chairs for distance. The idea of keeping 6 feet apart in ordinary moments had not yet entered the shared vocabulary of daily life. Workplaces in the United States varied, yet many shared the assumption that most jobs required physical presence. Office workers clocked in at headquarters, sat in conference rooms for meetings, and traveled for in-person sales calls and training sessions. Restaurants depended on servers, cooks, dishwashers, and hosts working shoulder to shoulder in tight kitchens and narrow aisles. Factories and warehouses relied on assembly lines and packing stations where people stood close together for long shifts. Remote work existed for some, especially in technology and consulting, but it remained the exception. The idea of empty towers became something rarely seen in fiction. Digital technology kept Americans more connected than ever through phones, laptops, and social media feeds. Video calls linked distant relatives and business partners, while text messages and group chats filled quiet moments at desks, in classrooms, and on couches. Yet for many, the default way of staying close still involved being in the same room. Book clubs met in living rooms, faith groups gathered in fellowship halls, and co-workers went out for drinks after long days. The constant stream of online information sometimes felt overwhelming. Few people imagined it would soon be their primary window into work, school, and friendship. Below the surface of this apparent normal, deep inequalities shaped how health and security were experienced long before any mention of a novel virus. Many low-wage workers lacked paid sick leave and felt pressure to keep working through coughs and fevers so that rent and groceries could be covered. Black, Latino, and indigenous communities faced higher rates of chronic conditions like diabetes and heart disease, tied to long histories of unequal access to care and healthy environments. Rural areas struggled with hospital closures and long drives to specialists. These patterns already set the stage for very different outcomes ahead. Politics in the United States during the late 2010s were marked by sharp divisions that touched news, conversations, and even family gatherings. Debates over immigration, health insurance, and the role of government filled talk shows and online threads. Many people chose news sources that matched their views, following hosts and commentators who spoke to their fears and frustrations. Trust in institutions, including the federal government, had eroded for many, though others still believed official briefings and expert panels. The shared experience of receiving one clear, unquestioned message had grown rare. This fragile trust would matter greatly once a crisis arrived. Scientific research in the United States stood at a powerful moment, with expertise in virology, immunology, and genomics. University labs sequenced genetic material, studied how viruses entered cells, and modeled how diseases might spread through populations. Pharmaceutical companies explored new vaccine platforms and antiviral drugs, guided by trials and regulatory steps that took years. Many scientists warned that another pandemic was not a question of if, but when, though those warnings rarely dominated public attention. Grants were awarded and projects advanced in cycles that felt slow and steady. The public often saw this work only when a breakthrough made headlines in nursing homes and assisted living centers. Life followed routines set long before anyone heard the term COVID. Residents ate meals together in dining rooms, played cards at shared tables, and gathered for sing-alongs and visits. Staff balanced medication rounds, bathing schedules, and family phone calls while trying to create a sense of home. Infection control often focused on flu season, with reminders about hand sanitizer and recommendations for visitors who felt sick to stay away. Many facilities operated with limited staff and tight budgets. Few expected these buildings to become some of the most vulnerable places in the country. For children and teenagers, life before the pandemic held its own pressures, yet it unfolded in hallways, cafeterias, and playgrounds that felt familiar. Students navigated social groups, homework, and after-school activities, while teachers monitored grades and occasional reports of bullying or anxiety. Mental health concerns were rising, and counselors worked to keep up. But school days still centered on physical attendance. Snow days were cherished interruptions, not templates for remote learning. Parents juggled schedules, carpools, and childcare with the assumption that school buildings would be open. Few imagined entire districts closing for weeks, let alone months at a time. The broader economy showed a mix of strength and fragility in the years leading up to the first reports of a new virus. Unemployment numbers were relatively low, and many indicators suggested growth. At the same time, large numbers of Americans lived paycheck to paycheck, with limited savings to cushion any shock. Service industries such as hospitality, retail, and food service relied heavily on hourly workers whose schedules could change week to week. Gig work grew, offering flexibility but little security. Beneath the surface of growth, many households were one emergency away from difficult choices about rent, food, or medicine, government agencies kept emergency plans on shelves and servers, outlining responses to hurricanes, wildfires, terrorist attacks, and potential pandemics. Training exercises sometimes imagined a fast-moving respiratory illness, testing how federal, state, and local officials might coordinate. These drills highlighted concerns about hospitals filling up and supply chains straining, yet they competed with many other priorities. Funding for preparedness rose after scares and then dipped when memories faded. For most elected leaders, daily focus stayed on budgets, elections, and local crises. The detailed playbooks existed, but they were not always tied tightly to the realities of day-to-day governing. In everyday American life, protective masks appeared mainly in certain workplaces and a few familiar settings. Dentists and hygienists wore them while leaning over patients, and some construction workers used them to guard against dust and fumes. In airports, travelers sometimes noticed a handful of people wearing masks, often visitors from countries where that practice already signaled respect and caution. For most, it remained a curiosity rather than a model to follow. The idea that entire cities might someday adopt universal masking in grocery aisles and classrooms felt far away. Public health guidance did not yet center on that image. In this world before COVID-19, daily routines carried forward with a kind of quiet confidence that serious disruption would likely come from familiar causes like storms or recessions. People planned weddings a year ahead, booked vacations months in advance, and sketched out savings goals on notepads and apps. Schools, workplaces, hospitals, and governments all assumed that close physical contact was part of how life simply worked. A fast-moving virus capable of reshaping all these spaces seemed distant, even when experts warned it was possible. The stage was set, even if most Americans could not yet see the fault lines. COVID-19 first appeared in American awareness as distant headlines from Wuhan in late 2019, then as a slowly sharpening concern in the early weeks of 2020. At first, it felt like another far-away outbreak that might stay contained, the kind of story that filled a few minutes on nightly news before moving on. People in the United States watched maps with small dots, but most daily routines continued unchanged. In Wuhan, doctors and nurses faced clusters of patients with fever and shortness of breath that did not fit familiar patterns. Local health officials reported unusual pneumonia cases, and laboratories worked to identify a new virus. A young ophthalmologist named Li Wenliang warned colleagues in late December, only to be reprimanded by police. His story would later become one of the early symbols of ignored alarms. Global health agencies watched the reports from China with growing attention as numbers rose and new cities appeared in briefings and bulletins. The World Health Organization shared updates and technical guidance while asking whether human-to-human transmission was firmly established. Flights leaving Wuhan carried students, workers, and families towards cities across Asia, Europe, and North America. On screen, red circles on world maps slowly widened. In the United States, health officials began to prepare quietly, while most people looked toward ordinary winter concerns like flu, weather, and work. The Centers for Disease Control and Prevention issued travel notices and started screening some passengers from Wuhan at major airports. At arrival gates, a few travelers had temperatures checked and answered questions. For the rest of the terminal, life moved with its usual speed as scientists in China and elsewhere sequenced the virus now known as SARS-CoV-2. International teams raced to share data. Genetic information traveled by email and online databases, even as physical movement grew more restricted. Researchers in the United States downloaded sequences while sitting in quiet offices and labs. They studied the structure of the spike protein and began imagining vaccines that might one day block it. In January 2020, COVID-19 stopped being only a distant story when the first confirmed American case appeared in Washington state. A man who had recently returned from Wuhan developed symptoms and sought care at a clinic where careful staff connected his travel history with the news. He was guided into isolation and transferred to a hospital room. Outside his door, nurses adjusted gowns, gloves, and masks with extra care. The story of this first patient spread through news articles and televised briefings that showed still images of hospital exteriors and busy laboratories. Viewers saw officials standing at podiums, explaining that the risk to the general public remained low. They heard reassurance that the system was working as designed. For many, it felt like a contained episode that experts would handle somewhere off stage. Yet behind the scenes, the number of people under observation grew as returning travelers were asked to stay home, monitor temperatures, and report any cough or fever. Some were brought to military bases where rows of temporary housing and cordoned walkways appeared on evening news footage. Staff delivered meals in disposable containers to room doors. For those inside, days were measured in phone calls and nasal swabs. On January 30th, the World Health Organization declared the outbreak a public health emergency of international concern, a formal signal that this crisis reached beyond national borders. In the United States, federal officials announced restrictions on travel from China and mandatory quarantines for some arrivals. Airports added new signs and designated screening areas. Families watched arriving passengers answer questions under bright fluorescent lights. Through February, many Americans followed COVID-19 as a serious problem for other countries, while daily life at home still ran through crowded restaurants, offices, and arenas. News segments showed images from Wuhan of sealed apartment buildings, masked workers spraying streets, and temporary hospitals rising quickly. At the same time, anchors reminded viewers that only a limited number of cases had been detected inside the United States. The danger still felt hazy. One of the first widely watched outbreaks outside mainland China took place aboard cruise ships that had once promised carefree vacations. The Diamond Princess sat in port in Japan, with thousands of passengers confined to cabins as cases rose each day. News helicopters showed the white ship floating still against grey water. Viewers saw crew members in protective gear delivering trays to doorways along narrow corridors. Reports from South Korea, Iran, and Italy began to show how quickly COVID-19 could move once it found crowded gatherings and unnoticed chains of transmission. In northern Italian cities, intensive care units filled, and local officials urged residents to stay home. Images of empty piazzas and shuttered cafes reached American televisions. For some viewers, the sight of European lockdowns made the threat suddenly feel closer. Inside the United States in February, routine life and warning signs existed side by side. Basketball arenas still filled with fans wearing team colors, and music venues hosted crowded shows. Conferences gathered thousands of attendees in hotel ballrooms under soft chandeliers. At the same time, some hospitals began reviewing their emergency plans and checking supplies of masks, gowns, and ventilators more carefully. In late February, the sense of distance cracked when evidence of community spread appeared in Washington state, with no clear link to travel. An outbreak in a nursing home near Seattle led to hospitalizations and deaths among older residents and the staff who cared for them. Families stood outside glass windows, speaking on phones instead of entering. The idea that the virus had already been circulating quietly became harder to ignore. As cases appeared across different states, testing capacity in the United States lagged behind the needs that local doctors and patients were beginning to feel. An early test kit developed by federal scientists turned out to have reliability problems, and precious time passed while teams tried to fix the issue. Many hospitals could not yet run their own tests. Waiting rooms filled with people who wondered which infection they carried. Doctors in busy clinics sometimes had to tell coughing patients that they did not meet the exact criteria for a COVID-19 test, even when suspicion felt high. People with fevers were sent home with instructions to rest and isolate without confirmation. Phone lines at health departments rang steadily with questions. On social media, stories spread of sick families searching for answers and finding closed doors. As February moved toward its end, messages from leaders in the United States varied in tone and urgency. Some public health officials spoke plainly about the likelihood of wider spread and the need for communities to prepare. At the same time, other voices downplayed the threat or compared it to seasonal flu. Televised speech clips showed confident faces above flag-lined backdrops, promising that everything was under control. The news cycle reflected this split, with commentators arguing over whether the country was overreacting or not doing enough. In one segment, viewers could see a calm studio conversation about economic impacts, and in the next, they saw footage from overwhelmed hospitals abroad. Charts and graphs appeared more often on screens behind anchors. For people watching from home, it became harder to know which voice to trust. In homes and workplaces, conversations about COVID-19 became more frequent, even as schedules stayed full. Some people began washing their hands more often and avoiding handshakes, turning nods and small waves into new greetings. A few bought extra cleaners and canned goods during regular grocery runs, stacking them quietly in pantries. Others decided not to change anything, choosing instead to wait for clearer instructions. For Asian American communities, the early months carried an added layer of strain, as some people wrongly associated the virus with ethnicity or national origin. Reports emerged of rude comments on buses and sidewalks, and of customers avoiding certain restaurants. Shop windows in neighborhoods that had once been crowded stood quieter. Community leaders issued statements reminding neighbors that a virus does not recognize race or nationality. Inside universities and public health agencies, scientists used mathematical models to estimate how quickly COVID-19 might move if left unchecked. They adjusted assumptions, ran simulations, and watched lines on screens climb or flatten. Whiteboards filled with numbers and arrows as teams discussed possible outcomes. Many of these researchers warned that the window for containment was narrowing, even while the public conversation still felt uncertain. State and local health workers focused on contact tracing around each confirmed case, calling households and workplaces to identify who might have been exposed. Many worked long days in cramped offices surrounded by stacks of files and ringing phones. They explained quarantine rules and answered anxious questions from people who had been near someone sick. With every new case, the list of contacts to follow grew longer. Financial markets began to respond even before most workplaces changed their routines. In late February, major stock indexes dropped sharply over several days as investors reacted to reports of factory shutdowns abroad and disrupted supply chains. Television footage showed traders staring at falling numbers on large screens. For people with retirement accounts or savings in the market, the sudden swings added a new kind of unease. In corporate offices and university conference rooms, planning discussions shifted from routine schedules to contingency options. Leaders asked how work could continue if employees needed to stay home or if dormitories had to close. Some companies quietly tested remote access systems and video meeting platforms. A few large conferences were cancelled or converted to virtual events, leaving big convention halls unexpectedly empty on dates that had been booked for months. At the start of March, more cities reported confirmed cases, and local officials began to talk about limiting large gatherings. Some employers asked workers to cancel non-essential travel and bring laptops home at night. Press conferences mentioned social distancing, a phrase that still felt unfamiliar. In stores, shelves of hand sanitizer and disinfecting wipes started to thin. Families felt the shift in small ways as children came home with notes about hand washing and backup plans for school changes. Around kitchen tables, parents discussed what might happen if classes closed or grandparents needed extra protection. Some took one last carefree outing, not realizing how soon routines would change. By the time many Americans sensed that COVID-19 was near, the virus had already moved through airports, offices, churches, and quiet living rooms. The country was standing at the edge of a sudden change, with normal life still visible, but already beginning to slip. COVID-19 reached a visible turning point in the United States in March 2020. When ordinary days began to fold into emergency briefings, new rules, and a sudden sense that normal life was closing in. In the first week of the month, many people still commuted, attended games, and made weekend plans, even as maps on television filled with red circles and rising numbers. Within a short span of days, that easy motion through crowds started to feel uncertain. The month that began with busy schedules would end with empty offices, closed schools, and streets that sounded different at night. Inside the country, the meaning of COVID-19 shifted quickly between the start and middle of that month, as news from abroad collided with local decisions. World Health Organization officials declared a pandemic. Federal leaders announced a national emergency, and state governors studied graphs that suggested hospitals could soon be overwhelmed. For viewers at home, the language of flattening the curve entered living rooms, along with images of crowded intensive care units overseas. The idea that staying home could protect nurses, doctors, and neighbors began to take hold in scattered conversations. On a single evening in March, COVID-19 became real for many Americans who had watched the story from a distance. News broke that a well-known actor had tested positive while filming abroad, and soon afterward, cameras captured confusion at an arena where an NBA game was abruptly postponed before tip-off. Within hours, the league suspended its season, and other sports organizations began to pause their schedules. For fans who had expected another night of competition, the sight of players leaving the floor and stunned commentators grasping for words marked a sudden change. At airports, the impact of COVID-19 showed up first as changing rules, and then as chaotic scenes when new travel limits were announced. After restrictions on many flights from Europe were declared, crowds of returning passengers pressed into long lines for screening at major hubs. People waited for hours in packed arrival halls, filling out forms and watching staff take temperatures under fluorescent lights. For some, the attempt to control entry into the country felt like protection, while for others, the crowded checkpoints seemed to hold their own risk. In state houses and city halls, leaders watched the spread of COVID-19 and weighed how far to go in limiting daily life. Some governors issued early orders against large gatherings, leading to the cancellation of concerts, festivals, and parades that had taken months to plan. Mayors spoke at press conferences beside health officials, asking residents to avoid crowded bars and to stay home if possible. The decisions arrived in uneven waves, so that one town might still host events, while a neighboring county shut its doors. In classrooms, the effects of COVID-19 appeared almost overnight, as school districts decided to close buildings and move lessons online. Teachers sent home packets of worksheets and lists of websites, not yet knowing how long the closure would last. Students carried backpacks filled with library books and personal items, saying quick goodbyes to friends in crowded hallways. Parents studied sudden announcements on phones and emails, trying to figure out childcare, meals, and new routines for days when buses would no longer arrive. For many white-collar workers, the turning point in COVID-19 arrived quietly in company emails that told employees to take their laptops home. Conferences were cancelled, travel was halted, and offices that had once been full of chatter shifted into long rows of dark monitors and empty chairs. Video meeting links replaced conference room numbers, and kitchen tables turned into makeshift desks with power cords running across floors. The daily commute shortened to a walk from bedroom to living room, even as the work itself often grew more tense. For people whose jobs could not move online, COVID-19 meant walking into risk, while others were told to stay inside. Nurses, aides, and respiratory therapists reported to hospitals and clinics, where new screening tents rose in parking lots and hallways were cleared to make space for possible surges. Grocery workers wiped carts, stocked shelves, and rang up long lines of customers, trying to keep distance that rarely felt possible. Delivery drivers and warehouse staff kept moving boxes from place to place so that millions could remain at home. In neighborhood grocery stores and big box retailers, the first weeks of COVID-19 brought scenes of shelves rapidly emptying. Customers filled carts with rice, beans, pasta, canned goods, and cleaning supplies, then turned down aisles where toilet paper and hand sanitizer had already vanished. Store employees tried to explain new limits per customer, while trucks struggled to keep up with sudden demand. For many shoppers, the sight of long lines and sparse shelves created a new sense of fragility around everyday items that had once been taken for granted. In hospitals, preparations for COVID-19 intensified as March moved forward, even before every patient wing was full. Administrators set up incident command centers with whiteboards covered in bed counts and staffing plans. Elective surgeries were postponed so that operating rooms and recovery areas could be converted into spaces for intensive care. Staff reviewed procedures for conserving masks and gowns, knowing that global supply chains were already strained and that every box of respirators might be needed soon. In New York City, the early rise of COVID-19 cases began to change how hospitals and neighborhoods felt from one week to the next. Ambulance sirens became more frequent on certain blocks, and hospital entrances saw a steady stream of patients arriving short of breath. Inside emergency departments, staff worked to separate suspected cases from other injuries and illnesses, rearranging waiting rooms and hallways. Subway rides grew quieter as more people stayed home, even before official stay-at-home orders were fully in place. In nursing homes and assisted living centers, concern about COVID-19 translated into strict visitor restrictions that changed daily routines for residents. Families who had once visited several times a week now waved through windows or spoke by phone to loved ones sitting inside common rooms. Activities directors tried to keep people engaged with small group programs and hallway sing-alongs that respected new distancing rules. Staff members checked temperatures at the start of shifts and watched closely for coughs or fever among residents who might be especially vulnerable. In countless homes, the arrival of COVID-19 in March 2020 meant that bedrooms, kitchens, and living rooms all had to carry more weight. Parents tried to join remote meetings, while children in the same rooms connected to online classrooms that sometimes froze or crashed. Meals that had once been rushed between practices and commutes now stretched into longer evenings where everyone remained inside. Families called grandparents to explain why visits had stopped, reassuring them that staying apart was a way to keep them safer. For many people, the emotional shift around COVID-19 in March was as striking as the visible changes in streets and schedules. Days that had once been filled with small, thoughtless contacts now required careful planning about who would be near whom and for how long. Simple acts such as opening a door, touching a grocery cart handle, or pressing an elevator button came with new questions. the sense of control that routine once offered gave way to a quieter, more cautious way of moving through each day. In March, official communication about COVID-19 became a daily fixture as national and state leaders held regular press briefings. Viewers saw charts displayed beside podiums and heard repeated reminders to wash hands, avoid crowds, and stay home if sick. At the same time, some messages conflicted about how serious the threat was and how long disruptions might last. People heard one tone of urgency from certain health experts and a different one from voices focused more on keeping the economy open. As information about COVID-19 spread, confusion also grew, especially on social media and in everyday conversations. Articles and posts circulated claiming that the virus was no worse than a seasonal flu, while others shared projections of overwhelmed hospitals and long shortages. Different communities responded in different ways, with some neighbors organizing mutual aid efforts and others arguing over whether closures were necessary. The lack of a single, trusted voice left many people trying to assemble their own understanding from fragments of news and personal stories. Economically, the shock of COVID-19 landed with rare speed as March unfolded and businesses closed their doors. Restaurants that had planned for busy spring weekends laid off staff or shifted to takeout only, hoping enough orders would come in to cover rent. Retail shops in malls and on main streets locked gates and put temporary closure signs in windows that soon began to feel less temporary. For workers whose hours vanished, filing for unemployment became an urgent task during days already filled with health worries. On city streets, the physical landscape of COVID-19 could be seen in closed storefronts, dark theaters, and far fewer cars on the road. Public transportation schedules were reduced, and buses that once carried standing room crowds now held only a scattering of masked passengers. Playgrounds and public parks posted signs about distancing or closed entirely, leaving swings and benches unused. At night, some neighborhoods grew quieter than residents could remember, with fewer late-closing businesses and less traffic passing outside bedroom windows. Religious and community life also shifted sharply under COVID-19 as March closures spread. Churches, synagogues, mosques, and temples suspended in-person services, moving prayers, sermons, and songs onto live streams and conference calls. Community centers that had once hosted senior lunches, recovery meetings, and youth programs shut their doors, leaving many people without familiar gathering places. Leaders worked to maintain connection through phone trees and online groups, even as they worried about members who were less comfortable with technology. On college campuses, COVID-19 turned what should have been an ordinary spring semester into a rushed departure. Students received emails instructing them to leave dormitories within days, pack their belongings, and prepare for classes to continue online from home. International students faced particular uncertainty as they weighed travel restrictions and visa rules while trying to find a safe place to stay. Commencement ceremonies that had once been imagined as large outdoor celebrations were first postponed and then moved to screens. Across the country, plans that had taken months or years to make were undone by COVID-19 in a matter of days. Couples postponed weddings, families scaled down funerals, and milestone birthdays passed quietly in living rooms instead of rented halls. By the end of March, Americans living through COVID-19 understood that the shutdowns were not a brief pause, but the start of a longer struggle. The first wave of closures reshaped schools, work, worship, and daily routines in ways that could not be quickly reversed. COVID-19 pushed American hospitals into unfamiliar territory as the first surges of patients arrived in emergency rooms and intensive care units in the spring of 2020 across cities like New York, Detroit, and New Orleans. In buildings that had long balanced busy days with familiar routines, the pace quickened and the stakes rose. Hallways once crowded with visitors grew quiet while gurneys lined the walls. The air itself seemed heavier as staff moved behind masks and shields. In emergency departments, the first wave of patients often appeared as a steady trickle that soon turned into a flood. People came in with fevers, pounding headaches, and a strange shortness of breath that did not always match how they looked at first glance. Nurses watched oxygen levels fall on small fingertip monitors, even in patients who could still speak in full sentences. The waiting areas filled with wheelchairs and stretchers instead of families reading magazines. Doctors and nurses learned to read new patterns on chest X-rays and heart monitors as COVID-19 revealed its particular damage. They saw lungs clouded with white where there should have been darker, airy spaces. Respiratory therapists adjusted oxygen flows and mask settings while watching patients struggle to inhale. Conversations at nurse stations shifted from broken bones and routine infections to questions about who might turn the corner and who might suddenly decline. Night shifts stretched longer under bright fluorescent lights. The early shortages of protective equipment turned everyday tasks into calculated risks for hospital staff. Boxes of masks and gowns were no longer simple supplies to be restocked, but carefully counted items shared between units. Nurses sometimes wore the same N95 mask for entire shifts, placing it carefully in a labeled bag between rooms. Face shields were wiped and reused. Staff who once walked freely from bed to bed now checked each layer of their gear before entering rooms with closed doors and warning signs. Inside intensive care units, beds filled with patients who needed help from machines to keep breathing. Ventilators hummed at the bedside, while monitors displayed heart rhythms, oxygen levels, and blood pressures in lines of color. Staff adjusted drip medications that supported failing organs and watched for small improvements, like a slight decrease in the amount of oxygen a ventilator needed to deliver. The usual balance between serious and moderate cases tilted toward high acuity care almost everywhere. Transformations spread throughout hospital buildings as COVID-19 numbers rose. Recovery rooms that had once held patients waking up from routine surgeries were turned into makeshift intensive care spaces. Conference rooms became staging areas for emergency supplies. In some places, stretches of parking garage and outside tents served as triage zones where nurses checked vital signs in the open air. Signs and tape on floors directed one-way traffic to limit crosspaths between different patient areas. Beyond the visible changes in layout, the emotional weight on staff grew heavier each week. Nurses who had always prided themselves on calm under pressure found themselves crying in supply closets between tasks. Physicians wrestled with the fear that they might carry the virus home to their own families at the end of a long shift. Environmental services workers who cleaned rooms after each patient understood that their work had become another line of defense. Everyone carried a private layer of worry beneath the routines. The absence of family members at the bedside made the experience of COVID-19 even more difficult for patients and staff. Visitor restrictions meant that people fighting for breath lay in rooms without spouses, children, or close friends sitting nearby. Nurses held phones and tablets so loved ones could see faces on screens and speak through small speakers. In quieter moments, staff described clasping a patient's hand so that no one had to be physically alone at the end. Ambulance crews felt the strain of COVID-19 as calls multiplied, and each transport involved more steps and more uncertainty. Paramedics arrived wearing masks, goggles, and gowns, moving through apartment stairwells and small houses where worried families waited. They checked vital signs, started oxygen, and lifted stretchers into rigs already stocked with disinfectant wipes and spare gowns. After each transport, crews cleaned surfaces carefully before answering the next call, knowing that delays could cost minutes for someone else in distress. In some cities, the surge of COVID-19 patients exceeded the capacity of hospital morgues and funeral homes, forcing officials to arrange temporary storage solutions. Refrigerated trucks parked quietly outside facilities became stark symbols of the scale of loss. Staff who had devoted themselves to saving lives now helped move those they could not save with as much dignity as possible. The presence of those vehicles on city streets reminded everyone how serious the crisis had become. Hospital chaplains and social workers carried a new level of responsibility as they tried to bridge distances between patients, families, and medical teams. Chaplains prayed over phone lines and video calls, their voices steady even when their own hearts felt heavy. Social workers explained policies and updates to relatives who could not visit, answering repeated questions with patience. They helped plan small rituals and moments of connection that fit within strict infection control rules. Many communities watched their local hospitals with a mixture of fear and gratitude as COVID-19 surged. Outside some facilities, neighbors stood 6 feet apart on sidewalks holding handmade signs thanking healthcare workers. Restaurants donated meals, leaving labeled bags at staff entrances so nurses and doctors could grab food during short breaks. Children drew chalk arts and messages along the curb. These gestures did not solve shortages or exhaustion, but reminded staff that their work was seen. While big urban hospitals often made headlines, smaller and rural hospitals also faced serious strain from COVID-19. Facilities with fewer beds and limited intensive care capacity had to transfer some patients many miles away. Staff who had known each other for years covered extra shifts and cross-trained into new roles. Leaders worried about what would happen if several colleagues fell ill at once. The sense of being on the front line with fewer resources added another layer of stress. The pandemic shifted how hospitals thought about communication and teamwork. Morning huddles moved into larger spaces or onto video screens so that staff could stand farther apart. physicians from different specialties met regularly to share what they were learning about the virus and its complications. Nurses texted colleagues in other cities with questions about treatments, positioning techniques, and protocols. Information that once might have spread slowly through conferences was now traded in real time across time zones. One of the haunting features of COVID-19 care was how unpredictable the illness could be. Staff saw patients who seemed stable 1 hour suddenly struggle with life-threatening breathing problems the next. They watched blood clots appear, kidneys fail, and hearts strain under the effort to keep oxygen flowing. For every person who recovered and left the hospital, another might follow a more difficult path. This uncertainty demanded constant vigilance and made each improvement feel hard-won. People working outside the hospital walls also played crucial roles in the medical response to COVID-19. Primary care clinicians tried to manage milder cases through phone calls and early video visits, guiding patients on when to stay home and when to seek urgent care. Home health nurses checked on vulnerable patients while trying to minimize exposure. Pharmacists worked to fill prescriptions amid changing drug supplies and shifting guidance about which treatments might help. The entire system stretched together. Research hospitals and academic medical centers became testing grounds for new approaches to COVID-19. Physicians enrolled patients in clinical trials of antiviral medications, immune modulators, and supportive therapies. Ethics committees met frequently to review proposals and consent forms. While scientists sought better tools, bedside teams continued to rely on careful supportive care, positioning patients on their stomachs to improve oxygenation and watching for subtle changes in lab values. Progress felt incremental and full of uncertainty. As weeks turned into months, the mental health toll of COVID-19 on hospital staff deepened. Many reported difficulty sleeping, intrusive memories of particular patients, and a lingering sense of dread before each shift. Some experienced guilt over the patients they could not save, or decisions that had to be made when resources were limited. Peer support groups formed in break rooms and online, giving colleagues space to talk through their experiences and to remind one another that their efforts mattered. Beyond the immediate crisis, COVID-19 exposed and intensified long-standing inequalities in access to hospital care. Facilities serving predominantly Black, Latino, and low-income communities often saw higher caseloads and more severe disease. Many patients came from households where essential work, crowded housing, and limited sick leave made prevention difficult. Hospitals in these areas struggled with the same equipment shortages as others, while also caring for populations already carrying higher burdens of chronic illness. The patterns were painful, but not new. Some patients who survived COVID-19 left hospitals with new and complicated needs. After weeks on ventilators, muscles weakened, and simple movements like standing or eating independently became challenges. Rehabilitation teams designed exercises to rebuild strength and coordination. Speech therapists helped patients learn to speak clearly again after long periods with breathing tubes. Families prepared homes with extra equipment such as walkers, shower chairs, and bedside commodes for relatives stepping into a new stage of recovery. Telemedicine, once a small part of healthcare, expanded rapidly during COVID-19 as hospitals tried to reduce exposure risk while maintaining care. Doctors used laptops and tablets to check on patients in isolation rooms, saving protective equipment for essential physical exams. Clinics scheduled video visits for follow-up appointments that would previously have required travel and waiting rooms. Patients spoke with specialists from their couches or kitchen tables, sometimes with family members listening in from other locations. Financially, the impact of COVID-19 on hospitals had a complicated shape. Even as intensive care units filled with sick patients, many elective surgeries and procedures that often supported hospital budgets were cancelled. Rural hospitals that already operated with thin margins faced steep drops in revenue. Relief funds helped some stay afloat, yet did not erase the anxiety about long-term stability. The crisis highlighted how much of the system depended on predictable patterns of routine care that had been disrupted. For patients and families, memories of hospital care during the height of COVID-19 blended fear, gratitude, and grief. Some remembered watching staff disappear behind layers of protective equipment while offering reassuring words. Others recalled hurried phone calls from surgeons or intensivists who could not linger at the bedside. Many held onto specific moments, like a nurse adjusting a blanket with extra gentleness, or a doctor calling late at night to share a small sign of improvement. These details anchored stories that would be told for years. Community debates over masking, distancing, and closures affected how hospital staff felt about their own safety and the respect their work received. Some days, they drove home past crowded bars and unmasked gatherings, feeling that their efforts to save lives were being undercut. Other days, they saw neighbors masking carefully and dropping off donated supplies. The contrast between the calm intensity inside the hospital and the mixed responses outside added to the emotional complexity of the job. Over time, new treatment protocols and a better understanding of COVID-19 gradually improved outcomes in many hospitals. Teams learned which combinations of medications, oxygen strategies, and nursing practices tended to help. They developed clearer criteria for when to admit patients and when careful monitoring at home was possible. Even with persistent uncertainties, the sense of total novelty softened slightly. Staff could look back at the earliest weeks and see how much they had learned under pressure. By the time later waves of COVID-19 arrived, American hospitals had become both battle-tested and deeply tired. Their workers carried memories of the first surge in the spring of 2020, like a low, steady ache behind their daily routines. The systems they had adapted remained in place, but the human cost could not be reset. Behind the heavy doors of emergency rooms and intensive care units, lives had been changed in ways that would shape how Americans remembered the first long year of the pandemic. COVID-19 was the defining context of the first year of the pandemic in the United States, as millions of Americans tried to build new daily lives inside a long stretch of uncertainty. Work, school, family life, and small ordinary rituals all shifted indoors, slowed down, or vanished for a while. Morning routines changed first for many people, long before they understood how long the change might last. Instead of commuting toward offices or schools, they woke up to glowing screens on kitchen tables and quiet streets outside their windows. Coffee cooled beside phones as news anchors recited daily case counts. For parents and children, the first pandemic year turned homes into crowded, improvised classrooms. Kitchen chairs became desks, couches became reading corners, and the hallway floors became places to stretch during brief breaks between online lessons. Parents juggled passwords, mute buttons, meeting links, and homework questions at once, most weekday mornings, while many stayed home. Others still stepped outside each day to keep essential work moving. Healthcare workers, grocery clerks, warehouse staff, delivery drivers, and cleaners left sleeping neighborhoods before sunrise wearing uniforms and growing layers of protective gear. Families folded quiet worry into morning goodbyes and watched news carefully nightly. Trips to the grocery store became cautious expeditions instead of quick errands squeezed between other tasks. Shoppers waited in lines marked by pieces of tape on the floor, pushed carts down one-way aisles, and scanned shelves for flour, rice, and disinfecting wipes. Eyes met briefly, then turned carefully away. Some neighborhoods developed new small rituals that helped people feel less alone during the long months. In apartment buildings, residents leaned on balcony railings at set hours to clap for hospital staff, bang pots and pans, or simply wave at neighbors across courtyards. Children drew chalk rainbows beside hopeful messages. Remote work changed the boundaries between public and private life as living rooms and bedrooms appeared on video calls. Co-workers saw bookshelves, pets, framed photographs, and unmade beds while discussing budgets, deadlines, or lesson plans. Children wandered into frames asking for snacks, and unstable connections froze faces mid-polite sentences. For people living alone, the first year under COVID-19 often felt like a long test of solitude. Weekdays and weekends blurred together as they cooked for one, streamed shows, and waited for short bursts of conversation through phones or laptops. Some tried new hobbies, while others held tightly to routine. In multi-generational homes, the first COVID-19 year meant constant calculation about risk, space, and shared air. Adult children worried about bringing the virus home from essential jobs. Grandparents worried about young people still needing to step outside, and everyone listened for coughs. Bedrooms became quiet retreats when tempers rose slightly. Across many towns and cities, neighbors organized informal safety nets to cover gaps that official systems could not always reach. People delivered groceries and medicines to older residents, checked in on friends who had lost jobs, and offered spare laptops for students without devices. Small handwritten notes shared phone numbers. Conversations about COVID-19 often unfolded in family group chats and neighborhood threads where information and rumor mixed together. Links claiming miracle cures, hidden plots, or harmless symptoms bounced between relatives alongside careful summaries from doctors, nurses, and public health agencies. Some families split over restrictions, while others accepted strict rules. Spiritual life also shifted during the first year of COVID-19 as churches, mosques, synagogues, and temples closed their doors. Families prayed around kitchen tables with live streams playing softly from laptops, lit candles beside televisions, or listened to recorded sermons while folding laundry. Silence replaced choir music in many familiar sanctuaries. Rites of passage that usually gathered large crowds took new shapes during the first pandemic year. Graduates drove slowly through school parking lots to receive diplomas through car windows. Couples held tiny backyard weddings, and birthdays were marked by drive-by parades of honking cars. Funerals streamed online. Grief stayed. Seasonal changes that once happened mostly outdoors were now measured from windows, balconies, and short-mast walks. People watched spring trees bud along quiet streets. Summer thunderstorms roll past darkened stadiums, and autumn leaves fall over playgrounds closed with yellow tape. Winter arrived with both holiday lights and deeper fatigue. For people already living with chronic illness or disability, the first COVID-19 year multiplied existing challenges. Routine appointments became risky, hospital visits limited, and simple errands more complicated as they tried to avoid exposure while still managing ongoing care. Many balanced fear with determination, adapting carefully to changed routines daily. Young adults starting careers or studies during the first year under COVID-19 faced a future that seemed to shrink and blur. Some moved back in with parents after jobs disappeared. Others stayed in small apartments with roommates, sharing cramped kitchens and patchy internet connections. Dating paused or shifted onto screens. Children experienced the first COVID-19 year through smaller circles that still felt enormous to them. Backyards became entire worlds where they rode bikes in tight loops, drew hopscotch grids, or practiced sports without teammates. Masks printed with cartoon characters or bright colors turned safety rules into something slightly less frightening. Teenagers spent much of the first pandemic year staring at screens for both school and social life. Group chats and video calls tried to replace hallways, cafeterias, and practice fields, but many still felt an ache for unscripted moments. Some improved grades, others fell behind. Many carried quiet fear inside. The economic shock of COVID-19 showed up inside homes as paychecks vanished, hours were cut, and gigs disappeared. Workers in restaurants, hotels, salons, theaters, and factories filed for unemployment, waited on hold with agencies, or refreshed websites hoping forms would finally process. Budgets tightened, plans shrank to rent and groceries for undocumented workers and people in the informal economy. The first year under COVID-19 carried particular strain. Many kept cleaning buildings, harvesting crops, or delivering food without access to unemployment benefits, stimulus payments, or stable health insurance. They faced the virus with fewer protections, even while supporting communities around them. People living in prisons, jails, and detention centers experienced the first pandemic year within walls where distancing was nearly impossible. Dorm-style sleeping areas, shared bathrooms, and limited ventilation turned each cough into a source of dread for those inside and families on the outside. Shelters shared similar fears nightly. Many who caught COVID-19 recovered at home, riding out fevers, coughs, and exhaustion in bedrooms and living rooms. Friends dropped off soup on doorsteps, texted check-ins, or loaned small fingertip oxygen monitors that beeped with reassuring or worrying numbers. Every small improvement felt huge. Every setback felt suddenly frightening. Some people never felt fully well again after their initial infections, even if they had stayed out of hospitals during the first year. Weeks after acute symptoms faded, they reported pounding heartbeats, new brain fog, or crushing fatigue that followed even modest efforts. Daily life shrank around these invisible limits. Artists, musicians, and performers experienced the first year of COVID-19 as both a loss of stages and a search for new ways to connect. Gigs vanished overnight, theaters closed, and galleries locked their doors while online concerts, virtual museum tours, and driveway performances tried to fill the gap. Income lagged. Amid fear and loss, many people reached for small pleasures that could fit safely inside their homes and local streets. Some baked bread, tended balcony plants, or learned new recipes, filling kitchens with warm smells that helped mark time in long weeks. Others walked familiar blocks with newly careful attention. The politics of COVID-19 reached down into ordinary neighborhoods as people disagreed about masks, closures, and the balance between safety and livelihood. Some residents joined protests against restrictions, carrying signs and calling for businesses to reopen, while others stayed home and watched with unease. Relationships frayed when core views collided. The first COVID-19 summer unfolded alongside nationwide protests against racial injustice after the killing of George Floyd in Minneapolis. People filled streets wearing masks, holding signs, and chanting for accountability, even as they weighed the viral risk of joining large gatherings. Public health worries and demands for justice collided publicly. Later that year, Americans prepared for a presidential election shaped by COVID-19, which changed how people campaigned and how many chose to vote. Campaign rallies shrank or moved online. Mail-in ballots increased, and early voting lines curled around buildings as masked voters waited patiently at spaced intervals. Democracy adjusted. Mental health strains widened during the first year of COVID-19 as heavy isolation, financial stress, and constant uncertainty piled onto existing worries. Therapists shifted to phone and video sessions. Crisis hotlines reported higher call volumes, and some people turned to meditation apps or online support groups for the first time. Adaptation became a quiet theme of the first COVID-19 year as people adjusted rituals, expectations, and daily habits without always having words for the change. Seniors learned video calling to see grandchildren. Teachers reinvented assignments for online platforms, and community organizers shifted new food drives and fundraisers into contactless operations. Near the end of the first COVID-19 year, news of vaccine approvals brought a different kind of waiting into American homes. People refreshed appointment websites, joined long phone queues, and watched images of early vaccinations in hospitals and pharmacies with cautious relief. To some, the first shot felt like sunrise. Not everyone welcomed vaccines in the same way, and COVID-19 deepened existing divides over trust, medicine, and government. Some eagerly rolled up sleeves as soon as they were eligible. Others waited for more data or for friends to go first, and some refused entirely. Kitchen conversations echoed those tensions daily. Throughout the first year of COVID-19, small acts of kindness threaded quietly through the strain. Postal workers left encouraging notes in mailboxes, neighbors shoveled each other's sidewalks, and strangers paid for the groceries of people ahead of them who came up short. Such gestures softened fear without fully erasing it. Experiences of the first COVID-19 year often varied by place, with dense cities and rural towns encountering different rhythms of spread and restriction. In some rural areas, life at first looked almost unchanged aside from masks in stores, while urban centers saw empty downtown cores and constant ambulance sirens. Deeply, screens became both lifelines and sources of exhaustion during the first year under COVID-19. People refreshed news apps late into the night, scrolled through charts of rising numbers, and read personal essays from strangers describing symptoms, recoveries, and losses. Many vowed to unplug, then reached for phones again minutes later. Emotionally, the first pandemic year under COVID-19 carried a swing between hope and heaviness. Good news about a neighbor's recovery, a negative test, or a vaccine milestone could lift spirits for a while, only to be followed by reports of new variants or rising deaths. Feelings shifted again and again. By the end of that first year with COVID-19, Americans carried memories of empty streets, glowing screens, and countless small adjustments. Some losses were sharp, others quieter. Yet nearly everyone could point to specific days when they realized life would not simply snap back. They kept walking with that knowledge. COVID-19 turned masks, distance, and everyday choices in the United States into visible symbols of risk, responsibility, and disagreement that stretched across the first long years of the pandemic. What began as health guidance soon shaped store doors, sidewalks, and family conversations. A thin layer of fabric carried heavy meaning. At the start of the pandemic, official advice about masks under COVID-19 shifted as experts weighed supply shortages and changing evidence about how the virus traveled through air. Early guidance stressed hand washing and surface cleaning. Some leaders warned healthy people not to mask, hoping to reserve scarce supplies for hospitals. As Americans saw images from Asia of commuters and shopkeepers masking routinely, reactions ranged from curiosity to dismissal. For some, the sight looked unfamiliar and distant, tied to other cultures and earlier epidemics. Others quietly began covering their faces in airports and crowded spaces, feeling cautious without wanting attention then. Once community spread of COVID-19 became clear, masks moved from optional habit to strong recommendation in many places, and each face covering began to send a social signal. A cloth mask could mean concern for grandparents, respect for nurses, or compliance with rules. Its absence sometimes came to mean defiance. Distance joined masks as another visible rule under COVID-19, expressed in simple instructions to stay 6 feet apart. Grocery stores placed taped boxes on the floor near registers. Parks posted new signs, and offices removed chairs from meeting rooms. People learned to estimate space with glances and cautious steps outside. Signs explaining COVID-19 precautions multiplied on doors, windows, and walls as businesses tried to translate guidance into practice. Some printed posters with diagrams of droplets and arrows. Others used handwritten notes that asked customers to mask and keep distance. One way, arrows on store aisles nudged traffic into careful loops as cases rose under COVID-19. Some states and cities issued mask mandates that turned individual choices into formal rules. Store managers became unexpected enforcers, standing at entrances to offer disposable masks or ask unmasked customers to leave. Many complied quietly, while a few confrontations were filmed and shared widely online. For people who rejected masking under COVID-19, the fabric on their faces came to stand for personal freedom and suspicion of official narratives. Some argued that mandates violated rights or exaggerated danger. At protests and in interviews, they framed bare faces as statements of independence in the face of fear. Masks during COVID-19 also carried quieter stories of identity and care. People sewed patterns from familiar fabrics, added school colors, or wore designs that matched religious clothing. Healthcare workers taped their names and hand-drawn smiles onto shields so patients could recognize them. Small decorations softened the strangeness slightly inside. Online, arguments over COVID-19 precautions turned masks and distance into recurring themes. Videos of confrontations in stores spread quickly, with strangers praised or criticized as heroes, cowards, bullies, or rebels. The same images were shared in different circles with opposite captions. A simple snapshot could fuel long threads of accusation. Language shifted as COVID-19 stretched on, with the phrase social distancing entering everyday speech alongside talk of 6-foot bubbles and pods. Some experts preferred physical distancing, wanting to preserve a sense of connection even as people kept apart. Families spoke of widening circles when inviting 1 or 2 visitors. Not everyone could keep strict distance under COVID-19, no matter how strong the guidance. Nurses leaned over beds to start IVs. Grocery clerks handed receipts across counters. Bus drivers shared air with passengers in narrow aisles. For them, masks and ventilation became central because distance was a limited luxury there. Political divisions in the United States shaped how COVID-19 precautions were understood and debated. In some speeches, masks were described as simple acts of respect and patriotism. In others, their importance was minimized or questioned. Televised briefings, talk shows, and campaign rallies presented different tones, leaving citizens sorting mixed messages. Governors faced COVID-19 with varying strategies, which meant masks and distancing rules changed at state lines. Some issued early statewide mandates and capacity limits, while others left decisions to counties or resisted restrictions. Residents who crossed borders for work or errands often moved between regions with different expectations and norms. Visible protests against COVID-19 restrictions appeared outside state capitals and city halls, where demonstrators carried signs and sometimes rifles. They demanded reopening of businesses and schools, questioned death counts, and framed mandates as government overreach. News cameras captured flags, handmade posters, and close clusters of unmasked faces filling narrow steps. Other gatherings during COVID-19 expressed support for strict public health measures and concern for vulnerable neighbors. Nurses stood silently in scrubs on sidewalks near protests, holding signs that describe their experiences inside wards. Community groups organized masked rallies that emphasized solidarity, remembrance, and shared responsibility rather than resistance to rules. At the local level, COVID-19 turned shop doors and yards into spaces where values were posted. Some businesses taped up no mask, no service signs beside ours. Others displayed messages opposing mandates, inviting customers who shared their views. Yard signs thanked workers or criticized leaders, often on the same street. Scientific understanding of COVID-19 transmission evolved in view, influencing how people thought about masks and distance. Researchers debated droplets and aerosols while studying choir rehearsals, restaurants, and buses linked to outbreaks. Over time, attention turned toward ventilation, fit, and time spent indoors. Guidance updated while households tried to keep pace. Schools became central to arguments about COVID-19 protections, especially around children and masks. Some parents saw masking and smaller classes as essential for safe in-person learning. Others worried about speech development, discomfort, or what they viewed as unnecessary caution. School boards heard public comments, sometimes late into the night. Universities met COVID-19 with campus mask requirements, testing programs, and rules about gathering sizes. Students walked across quads wearing face coverings in season, their voices muffled in lecture halls and dorm corridors. Resident assistants and security staff enforced policies that sometimes felt necessary and exhausting. College social life narrowed sharply. Religious communities navigated COVID-19 precautions in varied ways. Some congregations required masks, spaced chairs, and shortened services, framing these steps as acts of care for elders and those with health. Others resisted mandates, kept choirs singing without face coverings, and challenged restrictions in court, arguing that worship should remain unrestricted. Within families, COVID-19 precautions created new tensions over visits, travel, and holidays. One sibling might insist on masks and outdoor meetings, while another felt those steps were unnecessary or insulting. Adult children urged parents to cancel trips. Grandparents struggled with loneliness and measured hug requests against wrist charts and news. Arguments about responsibility during COVID-19 sometimes overlooked how masks and distance were harder to maintain for people in crowded housing or frontline jobs. Many Black, Latino, and Indigenous workers shared shifts in warehouses, transit systems, and nursing homes where exposure risk stayed high. Choices were shaped by income and opportunity. Enforcement of COVID-19 rules also raised concerns about bias and safety. Some feared that mask mandates could give police reasons to question people of color, or that requirements could conflict with bans on facial coverings in certain contexts. Civil rights groups urged careful approaches that emphasize support rather than punishment. Small businesses adapted to COVID-19 rules with creativity and strain. Restaurants installed plexiglass barriers, rearranged tables, and counted limited seats while trying to stay solvent. Hair salons extended hours to serve fewer clients at a time. Gyms marked boxes on floors and moved classes outdoors when weather and space allowed. Public transportation systems under COVID-19 balanced the need to move essential workers with the risk of enclosed spaces. Agencies posted mask notices, blocked off some seats, and reduced capacity on buses and trains. Drivers and operators worked shifts behind plastic shields or improvised barriers. Watching ridership fall, yet remain necessary, perceptions of COVID-19 risk influenced how strictly people followed masking and distancing advice. In neighborhoods that had heard sirens and stories of loss, precautions often felt urgent. In places with few visible cases, residents sometimes doubted the need for restrictions. The same guidance landed differently depending on lived experience nearby. As months of COVID-19 precautions stretched into years, many people experienced a deep fatigue that changed how they approached masks and distance. Early strict rules softened into occasional exceptions. Some began gathering indoors again, rationalizing choices as necessary for mental health. Others tightened habits, especially after losing relatives or friends. When vaccines for COVID-19 became available, public health guidance about masking shifted again in ways that people found confusing. At times, vaccinated individuals were told they could remove masks indoors, only to face new recommendations when variants spread. Each change fed arguments about competence, trust, and the balance of caution. By the time COVID-19 moved into later phases, masks on rearview mirrors and folded in pockets had become ordinary American objects, shaped by science, habit, and belief. Distance rules faded or remained, depending on local memory. Beneath those visible choices, deeper questions about trust, safety, and shared obligation continued quietly. Behind every visible COVID-19 precaution, supply chains strained and adapted. Factories shifted from clothing or automotive materials to masks, gowns, and filters. Volunteers sewed cloth coverings at kitchen tables, mailing them to hospitals or neighbors. Online tutorials taught pleats and nose wires, turning sewing skills into small public health tools. Misinformation about COVID-19 precautions complicated every effort to build shared understanding. Articles and videos claimed masks trapped carbon dioxide, weakened immune systems, or signaled submission, despite scientific evidence to the contrary. Friends forwarded links without checking sources. Public health workers spent time correcting rumors while urging testing, isolation, and vaccination. Courtrooms became another arena where COVID-19 precautions were argued and refined. Judges weighed lawsuits, challenging mask mandates and gathering limits, balancing individual claims with public health evidence. Hearings took place on video as attorneys presented cases from offices or homes. Rulings sometimes varied by region, adding another layer of complexity. Communities already navigating communication barriers under COVID-19 developed adaptations. Deaf and hard-of-hearing people struggled with opaque masks that hid lips and facial expressions. So some groups promoted clear face coverings and expanded captioning. Educators, interpreters, and families worked together to preserve connection while respecting medical guidance and risk. Historians noted echoes between COVID-19 mask debates and those of earlier pandemics. During the 1918 influenza outbreak, some American cities had already seen mask requirements, compliance, and resistance, including brief anti-mask leagues. Comparing past and present reminded people that arguments over liberty, duty, and science had surfaced before too. By the time COVID-19 precautions began to loosen in some places, Americans had spent years negotiating the meaning of cloth, space, and shared air. Masks and distance left marks on habits and relationships that did not vanish overnight. The search for safer ways to reconnect continued alongside new medical tools. COVID-19 entered a new chapter in the United States when vaccines moved from laboratory results to syringes in real arms, and hope began to share space with fatigue. In late 2020, after months of deaths, shutdowns, and distant connections, news of successful trials cut through the steady rise of case numbers. The idea that a small vial kept cold in special freezers might help reopen schools, protect grandparents, and ease the pressure on hospital wards felt almost unreal at first. Yet as announcements turned into shipments, and shipments turned into appointments, a cautious kind of optimism took root beside continuing uncertainty. COVID-19 vaccines had been developed on an unprecedented timeline, built on years of quiet research into coronaviruses and new vaccine platforms. Scientists in universities, federal agencies, and companies had studied how to teach immune systems to recognize spike proteins long before most people heard those words on the evening news. When the virus began to spread globally, that groundwork allowed teams to design candidates within weeks and move quickly into the long, careful process of trials. To many watching from the outside, the phrase emergency use sounded sudden, yet behind it sat layers of review, data, and debate. The large clinical trials for COVID-19 vaccines relied on tens of thousands of volunteers who rolled up their sleeves without knowing whether they were receiving the real shot or a placebo. Participants came from different ages, races, and health backgrounds because researchers needed to see how well protection held across a varied population. They reported side effects, returned for second doses, and waited with the rest of the country for results that would be analyzed by independent boards. When early data showed strong protection against severe disease, many scientists felt both relief and the weight of what came next. Regulators in the United States granted emergency use authorization for the first COVID-19 vaccines in December 2020, a decision that turned months of debate and analysis into a new kind of logistical test. Boxes packed with dry ice and carefully monitored sensors left factories and traveled by plane and truck to warehouses and clinics. Special freezers hummed in hospitals that had rushed to prepare for storage requirements measured in sub-zero degrees. In command centers and back offices, staff checked tracking numbers and schedules, knowing that each delayed shipment meant another day of waiting for people who were already at risk. In the earliest days of COVID-19 vaccination, priority went to healthcare workers and residents of nursing homes, people who had already carried much of the pandemic's weight. Hospitals set up vaccination clinics in auditoriums and conference rooms, where tired nurses and doctors lined up after shifts to receive their first doses. In long-term care facilities, staff organized schedules so that frail residents could be brought to common areas in small groups, sleeves rolled up over thin arms. For many, These first injections felt like both personal relief and an act of protection for the communities they served. Television cameras captured some of the first COVID-19 vaccinations in the United States, turning private medical moments into public symbols. Viewers watched nurses, respiratory therapists, and doctors sit in chairs under bright lights as syringes slipped into upper arms. Some raised thumbs, others closed their eyes. A few cried softly from a mix of relief and grief. For people watching at home, those images offered a rare glimpse of good news, even as daily death counts remained painfully high. As eligibility widened, the rollout of COVID-19 vaccines revealed both the capacity and the frailty of American systems. Appointment websites crashed under sudden demand. Phone lines kept people on hold for hours, and eligibility rules shifted as officials tried to match supply with need. In many places, older adults relied on younger relatives or volunteers to navigate online forms, while others lined up in parking lots before dawn, hoping for extra doses. The contrast between the promise of powerful science and the frustration of local logistics became a common topic at kitchen tables. COVID-19 vaccination patterns differed by region, exposing familiar divides between urban, suburban, and rural communities. Large city hospitals and mass vaccination sites filled news footage with images of long lines, color-coded lanes, and steady streams of vehicles pulling through drive-through tents. In rural areas, smaller clinics and pharmacies often carried much of the burden, sometimes serving patients who had driven many miles on two-lane roads. Mobile teams brought coolers and clipboards to church parking lots, community centers, and farm fields, trying to reach people whose lives could not stop easily for appointments. Even as many rushed to be vaccinated against COVID-19 as soon as they were eligible, others hesitated, delayed, or refused. Their reasons varied, tangled in history, politics, and personal experience. Some Black Americans carried family memories of medical abuse and neglect that made trust in new treatments harder to grant. Others feared side effects, doubted the speed of development, or followed leaders and media figures who questioned the science. In some rural and suburban communities, resistance to vaccination became part of a broader identity built around skepticism of federal power. Misinformation about COVID-19 vaccines spread quickly through social media feeds, group chats, and certain television programs. False claims linked vaccines to infertility, microchips, DNA changes, and hidden plots, often wrapped in emotional stories or professional-sounding language. Algorithms that were designed to keep people engaged sometimes amplified the most dramatic or misleading content, pushing it into millions of homes. Public health officials, doctors, and community leaders worked to counter these stories with calm explanations. But the speed and volume of rumor made the task difficult. Inside families, decisions about COVID-19 vaccination sometimes opened sharp divides. One sibling might schedule an appointment at the first opportunity, while another refused and warned about imagined dangers. Parents worried about whether and when to vaccinate children, listening to pediatricians while also absorbing constant online noise. Holiday gatherings and school events became tests of how far people were willing to bend for one another or hold firm to their own sense of safety. Even as vaccination campaigns advanced, COVID-19 continued to change through new variants that altered the balance between hope and fear. The Delta variant brought higher transmissibility and renewed surges that strained hospitals in regions with low vaccination rates. Later, Omicron spread with remarkable speed, leading to record case counts even among some vaccinated individuals, though protection against severe disease remained stronger. Each wave forced Americans to revisit questions they thought they had already answered about masks, gatherings, travel, and school closures. In response to these changes, guidance on COVID-19 vaccination continued to evolve, introducing the language of boosters and updated shots. Older adults and people with certain medical conditions were urged to receive additional doses to strengthen waning protection. Over time, recommendations expanded so that many adults and adolescents faced a growing series of decisions about when and how often to return for another injection. Pharmacies, clinics, and pop-up sites tried to keep pace, setting up booster days that felt both familiar and newly urgent. While many in the United States gained access to COVID-19 vaccines within the first year of availability, large parts of the world waited much longer. Wealthy countries secured early contracts and stockpiles, while poorer nations struggled to obtain enough doses for health workers and elders. Images of unused or expiring vials in some places contrasted sharply with appeals from clinicians in regions where even first doses were scarce. These differences highlighted long-standing questions about fairness in global health and the responsibilities of nations with greater resources. For individuals, living with COVID-19 in the era of vaccines meant adjusting expectations rather than returning to a simple before and after. Many learned that vaccination greatly reduced the risk of severe illness and death, but could not erase the possibility of infection. Stories of breakthrough cases circulated along with reassurances about shorter, milder courses for most vaccinated people. Households weighed factors such as age, health conditions, local case rates, and variant news when deciding which activities felt acceptable. For people with weakened immune systems, the arrival of COVID-19 vaccines brought complicated feelings. Some received extra doses, yet still produced limited responses, leaving them dependent on the precautions of those around them. Cancer patients, transplant recipients, and others on immune-suppressing medications often continued to avoid crowded indoor spaces even after mandates lifted. Their lives depended on a layered approach that included masks, careful social choices, and the hope that community vaccination rates would stay high enough to shield them indirectly. For nurses, doctors, and other hospital staff, COVID-19 vaccination campaigns brought both relief and new responsibility. Many remembered the fear of early surges and felt a personal sense of safety after their own doses, even as they continued to care for unvaccinated patients who arrived dangerously ill. Some spoke of moving from constant crisis toward a more sustainable, steady state, while others remained wary of declaring any turning point. They also became informal educators, answering questions in hallways, break rooms, and community spaces about side effects and benefits. Policy debates over COVID-19 vaccination brought another layer of tension to workplaces, schools, and public venues. Some hospitals, universities, and government agencies required vaccination for employees or students, arguing that such rules protected vulnerable patients and allowed safer operations. Several businesses and entertainment venues experimented with proof of vaccination for entry, which supporters saw as a way to reopen while reducing risk. Opponents viewed these requirements as coercive and unfair, leading to lawsuits, protests, and sometimes resignations rather than compliance. Despite disagreements, COVID-19 vaccination helped many businesses and institutions imagine more stable futures. Restaurants reopened indoor dining with renewed confidence, especially in areas with high vaccination coverage. Schools that had spent long months online returned to full classrooms, relying on a mix of vaccines, ventilation, and testing to keep outbreaks smaller. The ability to plan more than a few weeks ahead, even under changing conditions, felt like a significant change from the earliest months of the pandemic. Emotionally, COVID-19 vaccination marked a turning point that was clear in some ways and blurry in others. People cried in observation rooms after shots, texted photographs of vaccination cards to friends, and shared sore arm complaints with a kind of relieved pride. At the same time, they kept hearing about new variants, breakthrough infections, and unequal access, reminders that the story was not finished. Hope grew, but it was cautious and often complicated. Over time, COVID-19 vaccines helped shift the United States from emergency toward a more managed risk. Yet they did not erase the changes already made to work, school, and daily life. Families still weighed exposures, employers still revised plans, and teachers still adapted lessons. The search for balance continued into the long aftermath of these first vaccines. COVID-19 disrupted schools and workplaces across the United States, turning the steady rhythm of daily routines into a long experiment in distance, risk, and adaptation. For students, teachers, parents, and workers, habits that had taken years to build were undone in a matter of days when COVID-19 first closed classrooms in the spring of 2020. Many people assumed the interruption would last only a few weeks. Students left desks covered with unfinished projects, forgotten sweaters, and open notebooks, expecting to return after a short break. Teachers printed packets, grabbed binders, and carried home bags of papers, believing they were preparing for a brief storm rather than a new season of education. As weeks stretched into months under COVID-19, remote learning shifted from an emergency patch to the central structure of school for millions of children. Kitchen tables became desks, bedroom corners turned into reading nooks, and shared computers had to serve parents working from home as well as students logging into class. Internet connections that once handled streaming and games now carried full school days, and every glitch risked cutting a child off from a lesson, a teacher, or a friend. The shift to online school during COVID-19 exposed deep inequalities in access to devices, quiet space, and reliable broadband. Some students already owned laptops, tablets, or gaming computers that could run video platforms smoothly, while others relied on borrowed phones that overheated or froze. School districts scrambled to distribute devices and mobile hotspots, but supply chains and budgets limited how quickly those promises could reach crowded apartments and rural homes. In some households, siblings took turns attending live lessons because they had only one functioning screen. Teachers under COVID-19 had to reinvent their craft in real time while carrying their own worries about health, family, and income. Veteran educators who had spent decades writing on whiteboards now learned to share screens, create breakout rooms, and manage chat windows full of questions and side conversations. They tried to read engagement in tiny video squares, searching for raised hands, tilted heads, or the stillness that might signal confusion or quiet withdrawal. Many worked longer hours than before, planning digital lessons late into the night, while their own children slept in nearby rooms. For students, the disruption of school under COVID-19 was not only academic, but social and emotional. Hallway conversations, cafeteria jokes, and whispered comments during group work vanished into silent text chats or did not happen at all. Younger children missed playground games and classroom routines that helped them feel safe, while teenagers mourned cancelled dances, lost sports seasons, and the simple comfort of walking beside friends. Some students found they preferred the quiet of home, yet even they often felt the ache of long isolation. Students with disabilities and those needing intensive support faced particular challenges under COVID-19 school changes. Therapies that once involved hands-on guidance or specialized equipment had to move onto screens, where fine motor skills, sensory needs, and complex behaviors were harder to address. Families became co-educators and aides, helping children navigate schedules, prompts, and accommodations while juggling work and household responsibilities. Early childhood programs, where learning depends heavily on touch, play, and shared materials, struggled to translate their approach into distant activities that could keep 3- and 4-year-olds engaged. Older students living through COVID-19 faced a different kind of educational disruption as college campuses closed dorms, dining halls, and lecture rooms. Many moved back in with parents or squeezed into shared apartments, attending seminars from childhood bedrooms or crowded kitchens that were never designed as study spaces. Internships, research opportunities, and study abroad plans were cancelled or shifted online, narrowing the paths that students had counted on for experience and future careers. Graduating seniors entered a job market shaken by COVID-19, sending applications into companies that had frozen hiring, downsized, or vanished entirely. In workplaces across the country, COVID-19 rewrote the rules about where and how jobs could be done. Offices that had once valued in-person collaboration above all shifted almost overnight to remote work, leaving downtown towers with dark windows and empty lobbies. Workers carried monitors, chairs, and file boxes to cars and buses, then arranged them in spare rooms, closets, or corners of shared spaces to create makeshift workstations. Meetings migrated onto video platforms, where colleagues said hello to pets, children, and partners, drifting through the background as everyone tried to keep projects moving. For workers whose jobs could not move online, COVID-19 meant entering spaces that felt riskier than before, while much of the country stayed home. Grocery clerks rang up carts full of food behind plexiglass barriers. Factory workers stood beside humming machines, and janitors cleaned offices that others no longer occupied. Many of these workers earned low wages and had limited or no paid sick leave, making it hard to stay home even when they felt unwell or had been exposed. Their risks were often higher, yet their ability to shape workplace safety under COVID-19 was more limited than that of people whose jobs allowed remote work. Gig workers experienced COVID-19 as both a threat and a lifeline, depending on which side of each transaction they occupied on any given day. Food delivery drivers and rideshare operators kept moving through city streets, picking up meals, packages, and passengers while weighing each contact against the possibility of infection. App-based platforms framed this work as flexible and independent, yet many workers found themselves with little protective gear, unstable pay, and limited access to benefits if they fell sick. Customers sometimes tried to close the gap by tipping generously or leaving thank you notes, small gestures that acknowledged the imbalance between convenience and risk. Under COVID-19, the collision of work and caregiving responsibilities fell especially hard on women, who were more likely to shoulder childcare and elder care even before the pandemic. Mothers conducted meetings from cars parked outside schools or from bathrooms with closed doors while toddlers played in nearby rooms. Some reduced hours, turned down promotions, or left jobs entirely because the combination of remote school, limited childcare options, and employer expectations became impossible to manage. These exits often erased years of progress and would shape career paths long after immediate COVID-19 restrictions eased. For managers and executives, COVID-19 tested assumptions about productivity, trust, and the need for physical presence. Supervisors who once measured effort by hours spent at desks now had to judge results delivered through shared documents, emails, and video calls. Some embraced the change, discovering that workers could be highly effective from home while enjoying greater flexibility in managing their lives. Others worried that remote work under COVID-19 eroded team cohesion, made mentorship harder, and blurred boundaries in ways that would be difficult to reverse later. In factories, warehouses, and construction sites, COVID-19 turned break rooms, locker areas, and shared vans into points of concern. Unions and worker advocates pushed for better ventilation, hazard pay, staggered shifts, and clear protocols when co-workers tested positive. Some employers cooperated readily, installing air filters, spacing out stations, and offering sick leave so that infected workers could stay home without losing wages. Others resisted, arguing that costs were too high or that COVID-19 risks were exaggerated, leaving workers to decide whether to quit, protest, or keep showing up despite fear. As months passed and vaccines expanded, some employers under COVID-19 moved toward hybrid models that blended home and office work. Employees might come in on certain days for meetings and collaboration, then spend the rest of the week at home doing focused tasks. This approach promised reduced commuting time, fewer crowded spaces, and more flexibility. Yet it also risked splitting teams into visible and invisible groups depending on who could attend in person. Questions about fair promotion, evaluation, and inclusion under hybrid work remained open as organizations tried different schedules and policies. Commutes changed under COVID-19 in ways that rippled through entire regions. Workers who once spent hours on trains, buses, or crowded highways gained time at home. But cities lost some of the daily flow that had supported downtown restaurants, shops, and transit budgets. Office towers that had anchored local economies became quieter, and some companies began to question how much space they needed in expensive central districts. These shifts hinted at long-term changes in where people might live, work, and gather in the years after the most acute phases of COVID-19. For parents, especially those with younger children, COVID-19 erased many of the boundaries between professional and family life that had once been supported by school and childcare. Children appeared in the background of performance reviews, contract negotiations, and staff meetings, sometimes climbing into laps just as important points were being made. Some employers responded with patience, grace, and flexible expectations that acknowledged the strain, while others enforced rigid schedules that ignored the realities of life under COVID-19. The stories people told later about these months often centered on whether they felt seen or disposable in the eyes of their organizations. Workers who lost jobs during COVID-19 faced the task of rebuilding routines from the ground up, often while still living under health restrictions. Some enrolled in online courses, learned new skills, or shifted into entirely different fields, while others cycled between short-term gigs and long stretches of searching. Unemployment offices struggled with record volumes of claims, outdated computer systems, and backlogs that left families waiting weeks or months for support. The disruption of work routines under COVID-19 reminded many households how thin their financial cushions had been even before the crisis. Beyond the statistics, COVID-19 changed the daily rhythms of schools and workplaces in ways that reshaped how people understood time, effort, and rest. School bells, commute times, and standard office hours lost some of their authority as families and teams negotiated new schedules that tried to match energy, caregiving, and quiet moments. Some discovered that they could be more productive at unusual hours, while others missed the structure that once kept work and rest in clearer balance. Every schedule experiment carried costs and quiet lessons. The disruption of routine under COVID-19 also unsettled the identities that people drew from their roles as students, teachers, workers, and caregivers. A student who once excelled in orderly classrooms might struggle alone at home, while another who felt lost in crowded halls could thrive in the relative calm of online learning. Workers who had defined themselves by constant travel, full calendars, and visible busyness sometimes found it painful to sit still, refresh inboxes, and face quieter days. Others discovered strengths in flexibility and patience as the most intense disruptions of COVID-19 began to ease. Americans carried new expectations about what school and work could look like. They had seen classrooms exist on screens, offices function without shared hallways, and industries pivot toward remote and hybrid arrangements that once would have seemed impossible. Yet beneath those adaptations lay the quieter costs of exhaustion, stalled careers, unfinished schooling, and the strain of holding communities together through constant uncertainty. Those losses would emerge clearly as families, schools, and workplaces counted who and what had been left behind. COVID-19 brought a scale of loss to the United States that was hard to see clearly while it unfolded. Each day carried new numbers on screens, yet behind every digit stood families, co-workers, and neighbors whose lives no longer included someone they expected to see again. That gap deepened grief. COVID-19 death counts appeared on charts, tickers, and state dashboards. But many Americans struggled to feel what hundreds of thousands of losses meant. Local newspapers filled extra pages with obituaries, while funeral homes answered phones from families who had never expected to make arrangements so suddenly. The numbers felt distant. COVID-19 often turned an ordinary day into a dividing line between before and after with a single phone call. A nurse or doctor explained that a loved one was in the hospital, that oxygen was low, that visits were limited. Families listened, took notes, and tried to steady their voices. In many COVID-19 wards, final goodbyes happened through phones held by gloved hands or tablets balanced near pillows. Voices shook over weak connections as people said they loved one another, shared memories, or offered simple encouragement. The usual touch on a shoulder or hand was missing in those moments entirely. COVID-19 changed funerals and memorials into smaller, quieter gatherings that often felt incomplete. Families sat spaced apart in chapels, drove in long car lines past grieving relatives, or watched services on screens from living rooms. Hugs were replaced with nods and waves, and many promised future ceremonies that never came. For many people who lost someone to COVID-19, grief felt suspended in midair. Without crowded services, shared meals, and visits filled with stories, mourning became something held inside long after the first days passed. People went back to work remotely, yet emotional goodbyes had not truly happened anywhere for them. COVID-19 sometimes moved through entire families and friend groups, leaving several empty chairs where there had once been conversation and laughter. A single household might lose a grandparent, an uncle, and a cousin in the same season. Survivors carried overlapping griefs that touched birthdays, holidays, and ordinary days at once. The impact of COVID-19 on death and grief was not evenly spread across the country. Black, Latino, and Indigenous communities lost loved ones at higher rates, shaped by long histories of unequal access to care, exposure at essential jobs, and crowded housing. Each loss carried layers of injustice and memory. Among those lost to COVID-19 were many people whose jobs had kept others fed, transported, and cared for through the hardest months. Bus drivers, nursing assistants, warehouse pickers, teachers, and grocery clerks appeared in tribute posts and local news segments. Their absence left holes in both families and services everywhere. In rural areas facing COVID-19, the hidden toll of loss sometimes unfolded far from major headlines. Small hospitals watched neighbors and longtime patients decline, then called families who lived down the road. Communities held memorials on fairgrounds and in churchyards, knowing nearly every attendee had known the person personally. COVID-19 left a deep emotional mark on nurses, doctors, therapists, and aides who saw more loss in a single year than some had encountered in decades. They memorized faces, room numbers, and family stories that ended too soon. Many carried a quiet sense of unfinished goodbyes and second-guessing afterward. In nursing homes shaped by COVID-19 outbreaks, the grief felt both collective and deeply personal. Residents lost table mates from the dining room and partners from shared activities within days or weeks. Staff mourned people they had bathed, dressed, and joked with for years, while still reporting for shifts anyway. COVID-19 created thousands of newly bereaved children who lost parents, grandparents, or other primary caregivers. Some moved in with relatives who were already stretched thin, while others entered the foster system during a time of disruption. Teachers and counselors tried to support them through screens, listening for signs of pain. Across the country, COVID-19 grief blended with anxiety and depression in ways that sometimes hid the source of pain. People who had lost loved ones felt numb, irritable, or exhausted rather than openly tearful. Sleep patterns shifted, appetite changed, and a heavy sense of meaninglessness often settled over daily tasks. For many older adults, especially those living alone, COVID-19 grief was magnified by intense loneliness. Regular visits from children, grandchildren, or neighbors stopped for long stretches. Phone calls helped, but they could not fully replace a hand held during hard news or a shared cup of coffee at a table. COVID-19 also intensified private forms of harm, including domestic violence that sometimes rose behind closed doors. People trapped with abusive partners or family members had fewer chances to seek help or find safe places. Shelters adjusted operations for distancing, yet demand often outpaced their capacity to offer rooms to all. Under COVID-19, substance use disorders and overdoses rose in many regions, representing another hidden toll of the crisis. Isolation, job loss, and disrupted treatment programs pushed some people back toward alcohol or drugs they had been trying to avoid. Families mourned loved ones whose struggles had intensified in the shadows. COVID-19 grief often merged with fear about housing, food, and bills as layoffs and reduced hours stretched household budgets. Some families lost both income and the person who had always managed finances, leaving survivors to handle paperwork while still in shock. Missed payments and mounting debt added layer of worry, even for those who did not lose someone directly to COVID-19. There was a quieter grief for time and milestones that never returned. Weddings were postponed, graduations shrank, and reunions disappeared from calendars. People looked back on months spent apart and wondered what might have unfolded in an ordinary year. COVID-19 left many survivors carrying complicated feelings about why they were still alive when others were not. Some had recovered from severe illness, while roommates or co-workers had not returned home. Others had avoided infection entirely, yet a sibling or friend had died. Guilt mixed with relief and confusion inside. Beyond immediate loss, COVID-19 left many people living with long-term symptoms often called long COVID, which brought its own kind of mourning. People who had once been active found themselves breathless after short walks or overwhelmed by simple tasks. They grieved energy and independence while adjusting to unpredictable bodies. Living with long after effects of COVID-19 also meant facing doubt or misunderstanding from others. Some employers, relatives, or friends could not grasp why fatigue, brain fog, or pain persisted long after tests turned negative. People felt pressured to appear well, even when basic tasks left them drained for hours. For children and teenagers, COVID-19 created a hidden toll in interrupted learning, lost friendships, and long stretches of worry about sick relatives. Some fell behind academically when internet connections failed or quiet study space did not exist. Others carried constant fear that a cough at home might signal disaster someday. COVID-19 also weighed heavily on unpaid caregivers who looked after sick relatives, children at home, and elders at the same time. Many juggled medication schedules, online school, and remote work without real breaks. Their own grief for lost normalcy went largely unrecognized, even as they held everyone else together daily. In many faith communities, COVID-19 grief sparked both deep questions and new forms of support. Clergy led virtual services, called members who had fallen silent, and listened as people wrestled with feelings of abandonment or gratitude. Prayer chains, meal trains, and mutual aid funds grew, even when sanctuaries stayed empty. Across cities and towns, people created public memorials to mark COVID-19 losses that official ceremonies sometimes overlooked. Rows of white flags covered hillsides near government buildings, each representing one life. Names were read in long online streams. Candles were lit in apartment windows, and murals honored local residents and workers. In many households, grief related to COVID-19 was complicated by political arguments over how seriously to take the virus. Some people lost relatives who had dismissed precautions, while others felt anger when neighbors described the pandemic as exaggerated, even as local hospitals filled. Conversations at funerals and online turned sharp. COVID-19 also created rifts when misinformation convinced some people that deaths were staged or inflated. Families who had sat at bedsides or answered calls from hospitals felt unseen when their experiences were questioned. This disbelief added another wound, layering loneliness and frustration on top of sorrow that was already heavy. Historians and mental health experts compared COVID-19 to earlier periods of mass loss, such as past pandemics and wars. They noted that recovery often took years beyond the end of the immediate crisis. Communities needed time to tell stories, build memorials, and rebuild trust before the full impact became clear. Throughout the COVID-19 years, therapists, counselors, and social workers tried to help people carry grief that rarely fit into a single loss. Sessions moved online, with clients speaking from cars, bedrooms, and offices between responsibilities. Practitioners listened for trauma symptoms, offered tools, and reminded people that numbness could signal stress. Artists, writers, and musicians responded to COVID-19 grief with songs, essays, plays, and murals that tried to capture what statistics could not. They collected stories from nurses, delivery drivers, and families who had said goodbyes through glass or screens. These creative works offered language and images for for feelings many shared. For individuals living after a loss to COVID-19, rebuilding daily life often meant relearning simple routines without the person who had once shared them. Morning coffee, evening walks, or weekly errands now took place in silence. Some found comfort in these rituals, while others struggled to face them at all. In many places, communities organized specific tributes for workers lost to COVID-19 while serving others. Hospitals installed plaques, planted trees, or held moments of silence for staff who had lost their lives. Transit systems named depots or lines, and unions read lists of co-workers remembered for bravery and dedication there. Part of the hidden toll of COVID-19 was the struggle to ensure every person was named and counted. Some deaths were missed in early tallies or folded into broader categories. Researchers, journalists, and families worked together to reconstruct timelines, believing that accurate records were one more way to honor lives. COVID-19 grief revealed and deepened long-standing inequities in health, work, and housing, leaving some communities with far heavier burdens. Neighborhoods already struggling with pollution, limited clinics, and crowded apartments saw repeated loss. The unequal distribution of sorrow became a reminder that disasters rarely strike all groups in the same way. As years moved forward after the first waves of COVID-19, many people carried their grief in quiet personal ways. They kept photographs on desks, visited graves alone, or spoke to the air while doing chores. Certain songs, meals, or seasons brought memories back, folding loss into the fabric of life. Through all of this, COVID-19 left behind a landscape of loss that stretched far beyond official counts or brief news segments. The grief that settled in homes, workplaces, and communities would shape how Americans understood health, safety, and one another as they stepped into the slower work of long recovery. COVID-19 tested public health systems, government structures, and trust in the United States in ways that revealed both strengths and deep weaknesses. In offices, control rooms, and makeshift home workspaces, officials tried to track a fast-moving virus, issue guidance, and keep essential services running. Their decisions affected every hospital, school, and storefront. Some choices saved lives and built confidence. Others deepened confusion, widened divides, and left many Americans wondering whom they could believe again. Before the crisis, many Americans barely noticed the network of public health departments that watched outbreaks, inspected restaurants, and ran vaccination clinics. Under COVID-19, these small offices suddenly carried public expectations far beyond their size. Staff who once focused on localized problems had to manage statewide dashboards, school reopening debates, and outbreaks in nursing homes. Many worked from cluttered kitchens and dim offices at odd hours, trying to connect data, resources, and real people everywhere. At the federal level, COVID-19 response relied on agencies such as the Centers for Disease Control and Prevention, the Food and Drug Administration, and the Department of Health and Human Services, each with its own mandates. Coordinating their work required clear leadership and steady communication. At times, that coordination faltered. Changing guidelines, delayed test approvals, and public disagreements between scientists and political leaders made it harder for people to understand what the system truly knew. State governments carried major responsibility for COVID-19 rules, leading to a patchwork of orders that sometimes shifted at county lines. Governors declared emergencies, closed and reopened businesses, and ordered masks or left decisions to local leaders. Some states moved quickly, accepting criticism for acting too soon. Others waited longer, fearing economic damage, and then faced rapid surges. Residents watched neighboring states and wondered why something as basic as timing could look so different at all. COVID-19 exposed fragile supply chains that supported hospitals, clinics, and community settings. When global demand for masks, gloves, and ventilators surged, the United States found itself competing with other countries and even with its own states for shipments. Some crates were rerouted mid-flight. Governors spoke of bidding against one another, while hospital leaders counted dwindling stocks in storage rooms. Homemade cloth masks, improvised gowns, and reused respirators became symbols of both ingenuity and scarcity. Data systems under COVID-19 carried new weight as case counts, death totals, and test results moved from spreadsheets into public dashboards. Health departments that had once shared occasional reports now posted daily updates watched by millions. The numbers were imperfect, affected by delays, definitions, and gaps in reporting. Yet they shaped behavior, policies, and moods. People refreshed pages in the morning and at night, searching for signs that curves were rising or finally bending downward. Trust under COVID-19 often depended on where people got their information. Some followed public health agencies, local doctors, and scientists who spoke in careful, measured tones. Others listened mainly to talk shows, social media feeds, or community figures who framed the virus and restrictions in very different terms. The same event could be described as necessary protection or as an overreaction. In that split, neighbors and relatives felt as if they lived in separate worlds. National leadership under COVID-19 shaped how all other systems functioned. Televised briefings mixed scientific explanations with political messaging, giving some viewers confidence and leaving others doubtful. At times, public health experts and elected officials appeared side by side, yet emphasized different points. A cautious sentence about masks or distancing could be followed by a reassuring remark that the situation was under control. The tension between urgency and reassurance made it harder to maintain shared focus. Local governments under COVID-19 often stood closest to the practical consequences of national and state decisions. Mayors weighed closing parks, libraries, and small businesses, knowing neighbors might lose incomes even as infections slowed. County health officers issued stay-at-home orders and then faced angry calls and emails from residents who felt harmed. City councils debated mask rules, restaurant capacity, and eviction timelines. In those rooms, abstractions about risk turned into specific trade-offs and compromises. Courts became another arena where COVID-19 systems and trust were tested. Judges reviewed lawsuits challenging business closures, gathering limits, and vaccine or mask mandates, listening to arguments about constitutional rights alongside evidence from doctors and epidemiologists. Some rulings upheld restrictions as temporary protections, while others struck them down as overreach. These decisions shaped what officials could do in future surges. For many citizens, the back and forth added yet another layer of uncertainty and worry. For the public health workforce, COVID-19 brought both appreciation and hostility. Many professionals who had spent careers quietly tracking disease found themselves praised in one moment and attacked in the next. They received thank you notes and homemade meals, but also threats, protests outside their homes, and demands to resign. Some ultimately left their positions, exhausted by long hours and political pressure. Their departures created gaps in local knowledge that would be hard to replace. In the national conversation, institutions like the Centers for Disease Control and Prevention became symbols of both expertise and disappointment under COVID-19. People expected clear, consistent answers about masks, schools, travel, and testing. Instead, they saw recommendations that changed as evidence evolved, often without enough explanation. Some viewed these shifts as proof of incompetence. Others saw them as the natural result of learning in real time. Either way, confidence in public health guidance was shaken. Government responses to COVID-19 also included large economic measures meant to cushion the shock of shutdowns and illness. Congress approved stimulus payments, expanded unemployment benefits, and aid for businesses that agreed to keep workers on payrolls. Federal agencies supported eviction moratoriums and paused some student loan payments. These policies prevented deeper, immediate collapse for many families. At the same time, complicated rules and uneven access meant some communities waited longer or received far less help. Alongside formal systems, community-based responses to COVID-19 filled gaps that agencies could not easily reach. Mutual aid groups organized grocery deliveries, rent assistance, and rides to testing sites and vaccination clinics. Local organizations translated guidance into multiple languages and checked on elders who lived alone. These efforts often built trust more quickly than distant announcements. They showed how much resilience existed in neighborhoods, even as they also revealed the limits of official structures themselves. COVID-19 unfolded in an information environment where conspiracy theories and organized disinformation could spread quickly. Some groups framed the virus as a hoax, a plot, or a minor problem exaggerated for political gain. Others promoted unproven treatments while casting doubt on vaccines, masks, or testing. These messages eroded trust not only in government, but also in legitimate scientific work. People who believed them sometimes rejected care, putting themselves and their communities at greater risk altogether. Over time, various investigations and reviews examined how systems handled COVID-19. Government watchdogs, academic teams, and journalists studied supply failures, data problems, and the timing of key decisions. Some reports highlighted missed opportunities to contain early spread or protect nursing homes. Others pointed to successes in rapid vaccine development and economic stabilization. These analyses could not undo damage, but they offered roadmaps for reform. Whether those lessons would be fully applied remained an open question. COVID-19 pushed many institutions to rethink what preparation and resilience should mean. Hospitals reviewed stockpiles and staffing models. Health departments called for stronger data systems, more stable funding, and closer ties with community organizations. Schools and workplaces invested in ventilation upgrades and flexible technology. Private companies examined supply chains with new attention to single points of failure. These changes suggested that systems had absorbed some lessons, even as memories began to fade in quieter years. In the end, COVID-19 revealed how closely public health, government, and trust are woven together in American life. Policies and systems mattered, but so did the feeling that leaders were honest, humble, and willing to listen. When that feeling was strong, difficult measures were easier to accept. When it was weak, even sound advice struggled to take root. The aftershocks of those years continued, shaping how Americans viewed risk, authority, and one another going forward. Scientific advisory committees under COVID-19 tried to translate complex evidence into recommendations the public could use. Panels of experts reviewed trial data, weighed side effects against benefits, and voted in meetings broadcast online. When they recommended pauses for investigation, as happened after rare side effects appeared, some people saw this as proof that the system was catching problems. Others interpreted it as a sign that vaccines were unsafe. The same cautious step carried opposite meanings. Tribal governments faced COVID-19 with both vulnerabilities and strengths shaped by history. Many communities lacked sufficient healthcare facilities and relied on underfunded services, yet they also possessed strong local leadership and social networks. Some nations imposed early checkpoints and curfews, set up their own testing programs, and ran culturally grounded public education campaigns. These actions helped protect elders and preserve languages. They also highlighted how self-determination could be a vital tool in crisis situations. Immigrant communities experienced COVID-19 at the intersection of health systems and immigration policy. Some residents feared that seeking testing or treatment might expose undocumented status, even when officials said otherwise. Language barriers and limited translated materials left families piecing together guidance from friends, ethnic media, and community groups. In places where trusted local organizations shared clear information and helped navigate services, adherence to precautions often improved. Where trust was absent, confusion and vulnerability deepened further. Science communication under COVID-19 relied not only on national figures, but also on local clinicians who spoke directly with patients and neighbors. Family doctors, nurses, and pharmacists answered repeated questions about symptoms, isolation, tests, and vaccines. Their calm explanations sometimes reached people who distrusted larger institutions, yet still valued personal relationships. In exam rooms, parking lots, and pharmacy counters, these conversations built or rebuilt trust. They turned abstract recommendations into guidance tailored to real lives. Interagency cooperation under COVID-19 drew in parts of government not usually associated with health. Military logisticians helped move supplies, build temporary facilities, and staff vaccination sites. Emergency management teams coordinated with public health leaders to track hospital capacity and allocate scarce resources. In some regions, this cooperation worked smoothly and earned quiet respect. In others, turf battles and unclear authority slowed responses. These differences showed how much outcomes depended on relationships built before the crisis. As the immediate emergency of COVID-19 eased, the question for public health and government was whether trust could be rebuilt in quieter times. Some communities emerged with stronger bonds to local clinics, mutual aid groups, and responsive leaders. Others felt disappointment and anger. The same systems that had been stretched would be needed again for crises. How Americans remembered these years would influence whether they turned toward institutions or away from them when danger returned. COVID-19 in the United States meant Americans faced a long tale of illness, uncertainty, and adjustment as the virus moved from acute emergency toward a lasting presence in daily life. In the years after surges, attention shifted from overflowing intensive care units to quieter questions about what it meant to live with lingering symptoms. People who had survived infections found that recovery did not always follow a straight line. Others who believed they had escaped infection discovered that new variants could still reach them later. Their experiences redrew the shared picture of what getting better from the virus could mean. For many people, the phrase long COVID became a simple way to describe a complicated reality. Weeks or months after an initial infection, they noticed that fatigue lingered long past the last fever. Short walks left them breathless. Simple tasks like grocery shopping or folding laundry required careful planning and long rests. Others struggled with headaches, racing hearts, dizziness when standing, or a cloudy feeling that made reading and conversation harder. Symptoms would ease one day and surge the next, making it difficult to predict what tomorrow might bring. Some feared this unpredictable pattern signaled change rather than temporary recovery. Healthcare systems learned slowly how to recognize long-term effects of COVID-19 that did not fit older categories. Early on, some patients were told that their fatigue or pain came from anxiety or stress rather than the virus. Normal-looking test results complicated conversations. People arrived in clinics describing crashing energy, memory gaps, and strange new sensitivities, only to leave with few answers. Over time, patterns emerged as doctors compared notes, read case reports, and listened more closely. Yet many patients still felt they had to prove that what they were living through was real. That struggle added another burden. Across the country, new clinics began to focus specifically on long-term effects of COVID-19. These centers brought together pulmonologists, cardiologists, neurologists, rehabilitation specialists, and mental health professionals who could see different pieces of the same puzzle. Appointments often lasted longer than usual as staff traced symptoms back through each patient's infection and recovery. Physical therapists measured strength and endurance. Occupational therapists asked detailed questions about daily routines at home and work. Researchers collected blood samples, imaging studies, and survey responses, hoping to understand why some bodies recovered quickly while others remained stuck in a stubborn middle ground for years. Long before COVID-19, people living with conditions like myalgic encephalomyelitis and chronic fatigue syndrome had described similar patterns of crashing exhaustion after illness. For them, the rise of long COVID was both painful and familiar. They recognized stories of post-exertional collapse and brain fog that had once been dismissed. Some felt hopeful that new attention might finally bring research and respect to their long-overlooked conditions. Others worried that older patient communities would again be forgotten once the most visible emergency faded and news cameras moved on to other subjects. Their warnings about misunderstanding illness gained relevance and urgency. Living with long-term effects of COVID-19 did not only challenge bodies, it also strained minds and relationships. Many people grieved the loss of their old energy and roles. Parents who once carried groceries up flights of stairs now asked children for help. Workers who had prided themselves on reliability missed deadlines or needed frequent breaks. Friends sometimes pulled away, unsure how to respond when outings, calls, or texts were repeatedly cancelled. Anxiety and depression often followed, layered over physical symptoms in ways that could be hard to untangle in everyday life. Support groups, therapists, and networks helped soften weight. COVID-19 changed the healthcare landscape beyond individual experiences of long illness by accelerating shifts in how care was delivered. Telehealth visits that had once been rare quickly became routine for primary care, mental health, and some specialty consultations. Patients spoke with doctors from kitchen tables, parked cars, or workplace break rooms, saving travel time, but sometimes sacrificing privacy. Clinics learned how to manage digital waiting rooms and electronic forms. Insurers updated rules so that remote visits could be reimbursed. Even after restrictions eased, many providers and patients chose to keep this blended model as part of normal practice for care. Health systems also revisited basic questions about space, staffing, and airflow in light of COVID-19's lingering risks. Hospitals evaluated how quickly they could expand intensive care units, where to store emergency supplies, and how to protect staff if another surge arrived. Clinics and nursing homes considered ventilation upgrades, improved filtration, and more use of outdoor areas for visits when possible. Waiting rooms were reconfigured to reduce crowding. Hand sanitizer stations and mask dispensers stayed near doors. Infection control, once a specialized concern, moved closer to the center of planning for everyday operations across the healthcare system throughout cities and towns. The healthcare workforce entered the later years of COVID-19, carrying both experience and deep exhaustion. Many nurses, respiratory therapists, and support staff had considered leaving during the first brutal surges, but stayed out of duty, habit, or lack of options. Over time, burnout, moral distress, and low pay drove some to step away. Hospitals faced vacancies in critical roles. Rural areas struggled especially hard to recruit replacements. Training programs expanded enrollment. Yet new graduates arrived with less hands-on experience, having learned under pandemic restrictions. The system was left stronger in knowledge, but fragile in human capacity for the future. COVID-19's long tail also reached into insurance coverage and household finances. People with lingering symptoms often needed repeated appointments, tests, and medications that added up quickly. Some lost jobs, and with them, employer-based insurance, forcing them to navigate Medicaid applications or marketplace plans while still unwell. Surprise bills appeared when out-of-network providers had been involved in emergency care. Policymakers debated how to cover testing, treatment, and vaccines once early emergency funding expired. The question of who should pay for long-term consequences of a global pandemic became another unresolved thread in the national conversation for years ahead. Long COVID highlighted racial and economic inequalities within the American healthcare landscape. Specialized clinics often opened in large academic centers located in wealthier urban areas, far from many of the communities hit hardest by the virus. Patients without cars, flexible jobs, or childcare struggled to attend lengthy evaluations. Language barriers and mistrust rooted in historical abuses made outreach harder. Meanwhile, those with resources could travel, pay out of pocket, or navigate complex systems more easily. The risk was clear. The people most affected by lingering symptoms might receive the least consistent and comprehensive care over time, without strong, lasting reform. As COVID-19 moved from acute crisis toward a more chronic presence, public health surveillance shifted as well. Daily briefings about case counts faded in many places, replaced by broader monitoring systems that required less individual testing. Wastewater analysis became an important tool. By measuring viral fragments in sewage, scientists could detect rising levels in a community before hospitalizations climbed. Laboratories continued to sequence samples to track new variants and understand how they spread. This quieter background work allowed officials to spot trends, even when fewer people reported positive tests through clinics or home kits, especially for smaller local health departments. New variants kept COVID-19 from becoming a simple, predictable part of life. Waves of infection rose and fell, sometimes overwhelming particular regions, while others stayed relatively calm. Antiviral medications and improved treatments softened the blow for many who fell ill, especially those at higher risk. Monoclonal antibody therapies had their moment, then lost effectiveness as the virus changed shape. Each medical advance brought cautious hope, yet access remained uneven. Some people received prescriptions quickly after a positive test. Others could not find providers who understood the guidelines or pharmacies that had supplies when they were needed in their own communities. In the wider society, Americans adapted to living with ongoing COVID-19 risk by developing personal rules and routines. Some chose to mask in crowded indoor spaces, avoid large gatherings, or test before visiting older relatives. Others treated the virus more like seasonal flu, accepting occasional sickness as the price of normal activities. For people who were immunocompromised or living with long-term effects, these shifts were especially complicated. They depended on layers of protection, from updated vaccines to good ventilation, yet could not fully control the choices of strangers around them in stores, schools, and workplaces throughout their daily lives. COVID-19 also altered how many Americans thought about illness more broadly. Coughing in public spaces drew new attention. Some people chose to stay home with mild symptoms out of courtesy, a practice that had often been rare before. Workplaces and schools updated sick policies, at least on paper, to discourage attending while contagious. Masks became ordinary winter tools for some, used during peaks of respiratory viruses. For others, the desire to forget and move on remained strong. The culture settled into an uneven mix of new caution and a longing to treat everything as normal again, despite lessons many learned. In medical training programs, COVID-19's long shadow encouraged new conversations about chronic illness, uncertainty, and listening. Young physicians learned that not every condition fits neat diagnostic boxes or responds quickly to treatment. Lectures on long COVID covered immune responses, autoimmunity, and vascular effects, but they also addressed communication. Trainees were reminded to take patient reports seriously, even when tests were inconclusive. Research networks formed to share data across institutions, combining electronic records, patient surveys, and biological samples. The aim was simple: understand this one virus better and improve care for others living with persistent post-infectious conditions in coming years. Long COVID also forced policymakers to reconsider how disability, employment, and social support intersect. Many people who could no longer work full-time applied for disability benefits, only to encounter systems built for more clear-cut diagnoses. Evaluators asked for documentation that did not yet exist or misunderstood fluctuating symptoms. Employers wrestled with requests for flexible schedules, remote options, and modified duties. Some responded generously, others grew impatient. Advocacy groups pushed for recognition of long COVID as a disabling condition when symptoms warranted it, arguing that support now could prevent deeper poverty and instability later for families across the states. By the time the United States moved into its later COVID-19 years, long-term effects and lingering risks had become part of the landscape rather than rare exceptions. Hospitals, clinics, and public health agencies carried new knowledge and new scars. Patients carried pillboxes, inhalers, notebooks, and quiet hopes for better days. Families adjusted routines around energy limits and vulnerability. The healthcare system remained imperfect, yet more aware of how a virus could reshape bodies, institutions, and expectations. In that space, Americans slowly began to ask how to build lives that acknowledge these changes without being defined entirely by them. COVID-19 now lives in American memory as both a crisis and a long adjustment that continues quietly in daily life. Years after the first shutdowns, people still measure time by phrases like "before the pandemic" and "after everything changed." The event sits close beside ordinary routines, not fully past, yet no longer the only story. It settled into American habits. Many Americans remember the first strange weeks through small images that stay sharp. There were empty downtown streets with traffic lights changing for no one, homemade signs in windows, and taped arrows on grocery store floors. Some remember constant sirens at night, while others recall the hush of neighborhoods where planes rarely passed overhead. For many, those pictures never faded. Children and teenagers who grew up during COVID-19 often measure their own stories by grades and phases of the pandemic. They remember learning to read over video, masked playground games, and birthdays celebrated on driveways while relatives waved from cars. Their earliest impressions of school, friendship, and safety will always include these adjustments. Adulthood will carry those memories forward quietly. In later years, people learned to fold the memory of COVID-19 into lives that also had to keep moving. Some still count seats between themselves and strangers in waiting rooms and theatres. Others rarely think about distancing at all. Risk became something personal, managed through habits, history, health, and whatever trust remained in systems. Each household drew its own line. Workplaces did not simply snap back to their old shapes after COVID-19. Many offices stayed partly remote, with hybrid schedules that kept some desks empty on any given day. Video meetings remained common, even between people who worked in the same city. Commutes returned for some, but others built entire careers from kitchen tables. Work slowly felt less tied physically. Schools settled into new patterns shaped by what COVID-19 had revealed. Many districts invested in ventilation, outdoor spaces, and technology that could shift quickly between in-person and remote days. Teachers kept digital tools they had learned under pressure. Fire drills shared calendars with lockdown drills and health protocols, reminders that classrooms sat inside a different era. That difference lingered. Healthcare in the United States emerged from COVID-19, carrying new tools and visible scars. Telehealth remained an ordinary option for many appointments, especially mental health visits and follow-up care. Clinics and hospitals kept emergency plans closer at hand, aware that another surge or a different disease could appear more quickly than expected. Preparation felt less theoretical and distant. Public spaces kept subtle reminders of the pandemic years even as crowds returned. Hand sanitizer stood near entrances to libraries, arenas, and churches. Some people tucked masks into pockets each winter, ready for crowded buses or airplanes when respiratory viruses surged. Others walked through those same spaces, barefaced, grateful simply to gather again, without added layers. Memories waited quietly nearby. The pandemic years left lasting awareness of how uneven risk and security had been. Many Americans began speaking more clearly about essential work, recognizing how much daily life rested on people in grocery stores, warehouses, farms, and care facilities. Conversation about hazard pay, sick leave, and health coverage grew louder, even when policy changes moved slowly. Fairness questions stayed near. Trust in institutions did not heal overnight after COVID-19. Some people felt grateful for vaccines, relief funds, and exhausted nurses who had stayed at bedsides through the worst months. Others remembered changing guidelines, political arguments, and the feeling that their communities had been ignored. These different memories shaped how new warnings were heard. Future crises would meet that mixture again. Scientists carried their own long lessons from COVID-19. They had seen how fast collaboration could move when data, samples, and ideas were shared across borders and institutions. They had also seen how easily misinformation could erode public trust in careful work. Many turned part of their effort toward communication, trying to explain uncertainty more clearly. They expected another crisis someday. At the personal level, the memory of COVID-19 settled in uneven ways. Some people tried to avoid thinking about those years, focusing instead on work, family, and hobbies that had paused. Others kept news clippings, journals, and saved text messages from hard days. Both responses were forms of coping with something too large to hold constantly. Each memory found place. Writers, artists, and filmmakers began weaving the pandemic years into books, songs, and stories. Some works centered entirely on lockdowns, hospitals, and protests. Others treated the crisis as quiet background, a reason a character carried grief or changed careers. Over time, these reflections helped shape how future generations would picture a period they had never lived through. Memory entered culture. In American history, COVID-19 gradually took its place beside other turning points. People compared it to the influenza of 1918, the Great Depression, wars, and natural disasters. Yet the pandemic felt different to many because it touched nearly every household and stretched over years. It changed ordinary habits more than monuments or borders. Its traces appeared in workplaces, homes, rituals. Communities continued to mark losses from the pandemic in ways both public and private. Some cities established permanent memorials, planting trees, or installing plaques near hospitals and parks. Families held annual gatherings, lit candles, or cooked favorite meals for absent relatives. These acts of remembrance kept names present, turning statistics back into individual lives. They made space for shared mourning. In everyday life, the long aftermath of COVID-19 showed up in small choices. People opened windows more often, scheduled outdoor gatherings, and stayed home when they had fevers. Neighbors checked on one another during bad news more quickly than before. Simple acts of care, like grocery runs and phone calls, became familiar parts of community life. Ordinary routines carried caution. In politics, arguments over the pandemic slowly shifted into broader debates about health, security, and preparedness. Some leaders called for permanent investments in public health infrastructure, ventilation, and paid leave. Others argued that the country had already done enough and needed to move on. Voters carried their own memories into these choices, weighing promises against lived experience. Memories shape choices. At an inner level, many people noticed how their sense of danger had changed since the first alarms about COVID-19. News of new outbreaks or variants no longer caused the same shock. Yet it also never felt entirely routine. People developed mental risk maps for gatherings, travel, and seasons. Those quiet calculations became part of adulthood. Fear shifted toward planning. For some, the experience of the pandemic years prompted lasting reconsideration of priorities. People changed jobs, relocated, ended relationships, or deepened commitments they had once postponed. Time away from commutes and crowded calendars revealed what felt meaningful and what had only filled space. These decisions were part of the aftermath, even when they were never labeled that way. Change echoed. Those living with long-term effects of infection carried a different kind of adjustment into the future. Their days included energy budgeting, medical appointments, and careful planning around work and family responsibilities. Many became quiet experts on their own bodies and on navigating complex systems. Their experiences reminded others that the virus's story did not end quickly. It lingered quietly. Children who had drawn rainbows on sidewalks and learned to wave at friends from windows grew older. As adults, they told younger people about online school, mask collections, and long months when playgrounds were closed. Their stories gave the pandemic years texture beyond numbers. Memory passed forward in simple scenes that could be easily pictured. The event became family history. Later crises did not erase the memory of COVID-19. Wildfires, hurricanes, and heat waves arrived in the same country that had recently measured risk through case counts and hospital capacity. People compared their feelings, noticing what felt familiar and what did not. The pandemic became one reference point among several for understanding collective danger. Experience with uncertainty shaped later responses. A generation born after the earliest surges of COVID-19 encountered the pandemic mostly through stories, monuments, and traces in daily routines. They practiced drills, used hand sanitizer without thinking, and saw masks as ordinary objects. When they asked older relatives what it had been like, answers varied. Some emphasized fear, others resilience. Many described both together. History sounded close by. When Americans looked back on COVID-19, they saw more than a medical event. They remembered how the crisis revealed the strengths and weaknesses of their communities, governments, and workplaces. They also recalled the countless small acts of kindness that had helped them through. Together, these memories formed a complicated portrait of a nation under strain. Hope and hurt shared space. On the quiet evenings, long after the sharpest waves had passed, some people still found themselves thinking back to particular days. They remembered the last normal commute, the first empty grocery shelf, the moment a loved one's test result arrived. These memories came without invitation. Over time, they softened, but they rarely disappeared completely. They became part of how life felt. The long story of COVID-19 left Americans with a deeper sense of how connected their lives truly were. Air shared on buses and in break rooms, hospital capacity in distant cities, and choices made by strangers all mattered. The crisis had shown how quickly normal could change. It had also shown how people could adapt. Connection and vulnerability felt clearer. In the years after the first alarms, Americans slowly built a new kind of normal around what they had learned. It was not the same as the life they remembered from before the pandemic. It included more caution in some places and more gratitude in others. It asked people to hold grief and hope side by side. Balance defined afterwards. The story of COVID-19 became one chapter in the larger American story of hardship and response. Like other disasters, it revealed who had been protected and who had been left at the edge. Unlike some past crises, it touched nearly every home at once. That reach ensured it would remain present in national memory. It joined earlier stories of reckoning. For the people who lived through it, the pandemic years would never be just a topic in a textbook. They were stretches of life filled with worry, adaptation, loss, and unexpected care. Each person carried a slightly different version of that story. Together, those versions shaped how the country stepped forward into whatever came next. Aftermath quietly joined daily life. In the quiet of late nights or early mornings, listeners could trace this whole journey from ordinary days into crisis and back into a changed routine. The story did not offer simple answers, yet it showed how people tried to care for one another while living through uncertainty. That record now rests inside the broader hum of American life today.